on? Sure. Hello, hello. Okay. Okay. So can I try the slides? Yeah. And okay. So this is 2D, the introduction. So you don't need to wear your glasses. The glasses will be mainly for the live dissection. I need to thank the Escolab team for letting us this fantastic 3D exoscope. So the 3D will be only used during the dissections. So my idea, in order not to bore you too much, I will try to mix not only anatomy, but also how the brain was created, which is a fascinating story, and how we can take advantage of this knowledge, showing you some clinical scenarios. So indeed, this will be the first and the last slide of my long presentation today. And I need you to have a look at this. This is an MRI of the brain of one of my patients with a lesion that you can see here. It was biopsied, so that's why you can see this scar on the skin and the skull. And I need you just to think, where do you think that tumor is? Which structures of the brain are related to it? Is it left side, right side, frontal lobe, parietal lobe? So think about that, and think about this long path this tumor has in the lateral aspect of the brain. So this is the first slide, and it will be the last one also. This is a kind of experiment. So secondly, I need to really thank Professor De Pujari and Professor VERNON VELHO for putting this program together. It was my privilege. I have been trying to come here for the last 4 years, but it couldn't work, so I really thank you. All the team, anatomy and neurosurgery departments here in the hospital. I really appreciate what you're doing. And this is just an overview of where I'm coming from. Long distance. This picture I took it this morning, so it was night in my place in Alicante, which is, as you can see, Spain is very close to Africa, very close to Morocco, and this is my city, Alicante, which is in the east coast, very close to Valencia, and 4 hours driving from Madrid. And this is the beautiful landscape we have here, and you are all welcome to my place. This is the hospital where I work. This is the university where I work. I'm biased because I'm working for the Department of Anatomy, and at the same time I work for the Department of Neurosurgery, so that's why I'm so influenced about the anatomy and the brain. So all the pictures I'm showing you today, not only the clinical scenarios, but also the anatomy dissections have been done in these 2 buildings that I really appreciate. So I was told that most of you are medical students, and that's why I'm preparing this initial slide in which I'm showing you a coronal cut of the human brain, and this is the classic way in which we study anatomy in every medical school, which is fantastic because we can see in a 2D cut how the brain is arranged. But what we are going to do today is to see the same structures from a different perspective, from the, let's say, surgical perspective, which is, in my opinion, much more comprehensive to have an idea of the 3D orientation of all these tracts here, because you see only white substance there, but I will try to prove you today how the tracts are organized in this very important substance. First of all, I need to start with this introduction, because the brain is a very complex organ in the body, and for me it's very important to understand how it has been created, because it will give us a nice perspective about this very complex organization. So this is a nice journey I will show you, and starting defining a central nervous system, we must go almost 4,000 million years back. This is the first central nervous system, a bacteria, made of channels, that's it. So the bacteria are interacting with the environment and just reacting to it. This is the most primitive central nervous system. So from that very primitive one, we have created, the evolution has created for us a fantastic machine, which is our brain. How we have gone from that point to this point, 3 very important aspects. Mutations, that is something we cannot manage. Mutations appear spontaneously. Most of them are bad mutations, so they are not working, but 1 out of a million is a fantastic mutation. And then, if that fantastic mutation happens, the survival stress that an animal has and the environment in which this animal is living will take advantage of that mutation. And if we are adding more and more mutations, then we will have a perfectly designed central nervous system, and maybe we will create, the nature will create a new species. And this is how it's working. These 3 factors are the ones who converted this very rudimentary central nervous system in our fantastic machine, which is inside our skull, and I will show you how it happened. How do we know about that? Very important aspects: fossils, molecular studies, endocast, contemporary species. We analyze how these brains are working, but the most important thing is embryology, and this is why it's part of your training. Embryology is mandatory to understand how this evolution has happened. And the first one to realize that was Ernst Haeckel, who really he really thought that all the phylogenetic changes along the story, which are those mutations who are changing the central nervous system, are stored in the species embryology development. So which means that ontogeny recapitulates phylogeny. And this is not completely truth, but it's happening. And you will see, if you analyze the embryology of the different species, you will see some similar points, as you can see in these embryos evolution. So how it's happening? So let's go to a fish embryo on the intermediate stage, and a normal fish develops to a fish. That's very clear. But what happens if a positive mutation appears and these wings develop like limbs or feet? So what happens is that this is not a fish, this is an amphibia. So this is the change that is happening in this intermediate stage. And these fishes will not have this part of the embryologic development of the fishes will not appear in the amphibia, but yes, all the premutation stages. So those are the ones who are leaving a root in every single development. So in order to make this concept more clear, this is not truth, but this is truth. So we have a common embryo, and different mutations are giving different branches. And this is against the classic theory of the linear evolutive process in which the man is the king of the species. That's not truth. This is not linear, it's radial. So this is what's really happening. We are having different mutations and we are creating different species. So we are not the kings of the nature. So this is a new example. So starting from a limb, bats develop wings, dolphins develop kind of limbs, and humans develop this fantastic machine we have distal in our arms. So we are in the same route, but we are developing different limbs because we need them for different survival stress, and we live in different environments. So this is how it's working: mutations, survival stress, and environment. Going to the central nervous system, is it important, the size of our brain? So most likely could be, but it's not the most important thing about intelligence, and I will try to prove it to you. The most important thing is the combination of neurons and especially connections between those neurons. So here we have a small brain inside the chimpanzee skull, 400 cc's, and we have triple volume, but the shape is very similar, but the number of neurons is quite different. So this is the real key, how this is arranged. And this is the primates' evolution of different branches, central nervous system, and why our brain is bigger than other primates, mainly because of many aspects, but one of them was really studied, and you can see that in the evolution of these different species of primates, we have gone from very big masticatory bones with a small skull to the opposite, small masticatory apparatus with a huge skull. Why did it happen? Again, many factors, but as you know, primates are ruminants, so they really need a huge masticatory apparatus in order to, they are the whole day eating and chewing. But there was a mutation on this protein, which is mainly located in the masseterian muscles, and it happened 2.5 million years back. And this mutation, which could have been negative for them, was positive for us. So what happened is that this masseterian muscle was not properly developed, so the strength caused by this masseterian muscle on the skull, which was forcing the skull to get close earlier, is not happening in us. So we have more time to create a bigger skull, so our brain inside has more space to develop. So this is just a single mutation, and many other happened in order to create a big device inside our skull, but this is one of the things that happened. So this is how it happens. By chance, we had this opportunity. And at the same time, different mutations on this smaller masticatory apparatus, we were able to develop our pharyngeal muscles in order to be able to speak and to communicate with our relatives. So this is an overview how it is going. If we have a look at the intracranial volume, at the volume of the skull along the years, we can see that in the last, let's say, 200,000 years, the volume has increased a lot. And it happened at the point in which these mutations were happening. And exactly at that point, by chance or not, these species were able to hunt, recollect, and even cook. So this is the story. We couldn't be ruminants, but we developed some intelligence in order to hunt, recollect, and cook later on. Okay, I was talking about mutations, about survival stress, and the environment. And the environment is very important, and this is science. It has been proved that the biggest intracranial volume improvement or enhancement happened during the greatest climate fluctuations. So environment is affecting to the way in which we develop our organs. So survival stress, environment mutations, we had the bacteria, we had our brain. Now we can see how a single mutation gave us the opportunity to develop a huge brain. And this has been happening in the last 500 million years. So this rudimentary central nervous system of the fishes is becoming a huge central nervous system in our skull. But if we go to the chromosomes, to the genomic things, we share many, many things in common. So only small mutations happened in order to develop this tremendous brain. So going back to our brain, what do we have inside? How is it composed? Mainly of two different layers. The cortex, which is made of neurons, which is the external surface of the brain, and it's called pallium. Pallium is a Latin word which means cover. So this cover is this cortex, this pallium is covering the central substance, the cerebral substance, which is made of white matter and gray matter. So the white matter is divided in association, commissural, and projection fibers. Association fibers, they are mainly connecting different parts of the brain in the same hemisphere. And these are the most important ones in our brain. Commissural fibers are those ones who are crossing the midline, so mainly the corpus callosum and the anterior commissure, among others. And projection fibers are those ones who are ascending or descending to the brainstem, basal ganglia, and connecting these structures with the cortex, with the pallium, with our neurons. And then we have deep gray matter, basal ganglia, thalamus, and the hippocampal structures. But the cerebral substance is what we will try to do and to cover during our dissection. So this is the story of the evolution of the pallium. Pallium, remember that it's the cortex, the surface, the covering of our brain. So this pallium was named paleopallium, which means paleo means very, very old. So the oldest in phylogenetic terms, pallium, is that one which was covering the fish's brain 500 million years back. Mainly composed of 1 or 2 neurons, very, very basic, very rudimentary. Functions, memory, very short-term memory, and especially reaction to fear, so they wanted to survive. Almost 100 million years later, some mutations appeared, and these animals left the oceans thanks to the development of some limbs, and they became an amphibia and reptiles. So mainly this amphibia developed what we call the archipallium. And this archipallium, which is now green, is mainly located in the midline, as you can see. And this is in blue, the paleopallium. So the next species in the evolution, the reptiles, they needed to coordinate their movements in order to escape or to attack their animals. So these reptiles developed what we called the subpallium. And this subpallium indeed is what we have in our brain as the basal ganglia. You know, the basal ganglia are very important to coordinate our movements, and this happened a lot of years ago, many, many years back. So what made us different to these different species is what we call neopallium, which means very, very new pallium, the most complex arrangement of neurons, 5 to 6 layers of neurons which are covering our brain. And you can see it's very small in the paleo mammals, in the old mammals. But then these mammals started to develop their brain with new mutations, and this neopallium was pushing all these old structures, paleopallium, archipallium, to the midline. You can see it's in the middle of the hemispheres. So this is the so-called limbic brain. Limbus means the edge, so it's on the edge of the hemisphere. That's why. Okay, so we can see how this Archaea and Paleopallium, which were very important in the old species, now it's located in a hidden space in the midline. But this is very important to understand because we have these structures in our brain. And you can see how the Neopallium needed to create this sulci and gyri in order to increase and to expand its functional surface. Because our skull, despite the fact that it grew, it was not enough for this Neopallium to evolve, so that's why we have this sulcogyral pattern in our brain. So putting this on the table, let me show you a picture I took yesterday to try to explain how this sulcogyral pattern happened. Imagine this is the central nervous system, this is the pallium, the cover, the neurons, and we need to put that on the skull. So it's much better if we have these wrinkles, then it will fit inside. So this is how it was created. If we go to our coronal cut, this is the first layer I showed you, we can identify all these paleo and archipallial structures. So you see the paleopallium is mainly located 1-2 layers of neurons, rhinencephalon, which means mainly olfactory functions, located in the amygdala, the limen of the insula, and the olfactory structures. So this is mainly located in the base and medial aspect of the hemisphere. This is the old brain, mainly survival decisions, fear, reaction to fear, and some emotions. Then we have the archipallium, which is a little bit more recent in phylogenetic terms, and it's mainly located in the limbus, in the edge of the hemisphere. So mainly, we have the cingulum, which is surrounding the ventricle, and the parahippocampal. So you'd see it's like a kind of belt. So this is the very capricious shape that the limbic structures took in our brain. But we can even see the subpallium. You remember these reptiles needed to coordinate their movements? So this subpallium gave rise to our highly developed basal ganglia, putamen, caudate, and also the thalamic structures. Mainly limbic brain. But then we have our tremendous neopallium, which indeed gave us many important functions, highly developed visual function. We can understand each other, we can express each other with different languages, and this is thanks to the neocortex. 5 to 6 layers of very complex cytoarchitecture. So this is the neomammal brain. But coming back to the question we had before, is it important, the size? It is important, but the most important thing are the connections between all these neurons, mainly the association fibers. These association fibers are connecting, mainly connecting structures inside the same hemisphere. And these are the most important for the speech, for example, function, and even for the visual functions. So these association fibers that I will try to show you on 3D dissections are very important to our own development. So going to the clinical side, especially to our specialty, to neurosurgery, why is it important to understand this development and this complex arrangement of fibers and cortical structures? Is because of the understanding of how the brain tumors are growing inside our brain, so we can optimize the surgical treatment. And this is Professor Yazargil, and that's me when I was a trainee in Istanbul. He's the one who started, after observing many gliomas, which are the tumors which grow in this substance, how they grew. So he was able to observe thousands of gliomas and analyze their behavior. So he classified these neopallial tumors, tumors mainly located in the neocortex, as initial growth phase, in which we are not generally able to detect them because they don't destroy the fibers. They just push the fibers out. And this is an MRI of one of my patients where you can see how this big tumor is just pushing the fibers. This is the corticospinal tract, and you can see how the fibers are splitted. So if this glioma is growing in a relatively non-functional area, we will probably not be able to detect it because we will not have any symptom. But when it's coming to an area in which you have a very important function, we are lucky to detect it maybe in this initial growth phase. But if we are not able to do so, this tumor will start growing. How does a glioma grow? So it takes advantage of the highways which are in the brain that you already know. Association, commissural, and projection fibers. So these glial cells are invading adjacent and neighboring structures. which are the gyri around, or the different lobes. So mainly these gliomas are growing through the white matter network. So again, this is why it's important for us as neurosurgeons to understand this behavior, because if we understand how these glial cells are invading different structures, we will really understand which is the best surgical treatment for them, and we can even design the kind of surgery if we want to do an awake surgery or not, we want to stimulate some structures or not. So this is the key of our surgical treatment of gliomas. But finally, if we are not able to detect them and they appear in a very, very advanced stage, these glial cells need glucose, need oxygen, need blood to grow. So they start to take too much blood, so the adjacent structures are lacked of this blood, so they start to die. So they destroy the connections. And then maybe it's too late to offer a complete surgical treatment, because these glial cells could even invade both hemispheres or different structures. We call these tumors glioblastomas. And these are the terrible ones because we cannot really cure them. We can help the patients, but we cannot cure them because they are in a too advanced stage. So that's why it's important to keep this concept. Pathology follows anatomy. And this is why I truly believe that anatomy is the basis of any surgical and medical discipline. If you understand the anatomy, then you will properly understand what's happening with any single disease, not only in the brain, but in any other organ. So this is the main message I just wanted to send you. And maybe I should show you how we or you have prepared this hemisphere for the dissection, because what you are watching in your anatomy slides are these 2D cuts, coronal, sagittal, and axial, which are fantastic. But if we have the chance to see these 3D dissections, you will really put a 3D image in your mind, which will be really helpful in order to understand these structures. So this is how the brain is arranged. We have already covered how it was developed, why we can take advantage of this knowledge, and this is how it's arranged. So if we cut a gyrus with this coronal cut, we will see these external fibers, which are very short association fibers, which are in the depth of the sulci, and they are connecting adjacent gyri, as you can see. So these are the short association fibers. If we go a little bit more to the core of the gyrus, we will see these green ones, which are long association fibers. These ones are connecting different parts of the same hemisphere, different lobes, maybe. And in the center, mainly in the center of the gyrus, we have the projection and commissural fibers, which are those ones crossing the midline and ascending and descending to connect the cortex with deep structures. So this is how it's generally arranged. This is the preparation protocol, and we need to formalize our brains as fresh as possible for, let's say, 8 to 9 weeks, so they get strong, they get hard. We fix them, and then it's very important to freeze them. Why to freeze them for 10 to 12 days? Because the water particles that are in between those different fibers, they will expand. And if they expand, what we are getting is fibers with different directions. So that will help us to do a proper dissection, because you have fibers with completely different arrangements here, but if we freeze them, we will have a better chance to dissect those fibers which are following the same direction. So that was the introduction. Maybe we can, I don't know if this is ready for the dissection. Yeah, thank you, great. I don't know if you, maybe we can have some questions, or Vernon, up to you. Was it clear, understandable? Yeah? Some point to reinforce? Okay.
So no questions. We want to have this as an interactive session, okay? So you'll need to ask whatever doubts you'll have, whatever clarifications you'll need. I'm happy to see a full house. There's no place in the audience. That is good. And I see the eagerness to learn. And the reason for doing this is many of y'all who are sitting in this audience today might be in my place. Understood? Y'all might be becoming neurosurgeons one day. So we are also on the mission of exposing you all to the brain as early as possible, because those sitting in the audience, especially the students, you all might decide. That's how I decided. I decided to become a neurosurgeon not after joining medicine, but it was in my first year when I sat in the anatomy hall. And that's the time when I decided, yes, this, the brain fascinated me, and I decided to be a neurosurgeon from then. And your decision should start from first year. I remember asking a student just a few days back, I said, what do you want to do? He was in the second year, I think. And he said, I don't know, it depends on the marks. So you have to focus on what you want to be. That starts from first year, not when you are in third year or fourth year. You have to decide your pathway when you are in the first year. And you have to follow that pathway. You have to follow that road which you are going to make for yourself. And that happens in the first year. So I think the dean is a bit late. She's coming a bit late. So what we will do is we will go ahead with the dissection, and when she comes, we will welcome her. That would be better. For those who want to have some breakfast, breakfast is there, but you'll have to do it fast and come, or we will break later on. If Pablo, are you ready for the 3D? 2 minutes, okay, fine, yeah. Here only we can do it, or we should wait for the dean to come. We'll wait. Okay, fine. Yeah.
ब्रेकफास्ट है क्या रखते हैं इडली वड़ा शीरा लेने गए इडली वड़ा शीरा नहीं तो चालू कर रहे हो नहीं और 5-10 मिनट तो लगेगा कितना टाइम लगेगा अभी ये डिसेक्शन चालू करेंगे या फिर डीन आने के बाद इंटरप्ट करके सर ब्रेकफास्ट है ब्रेकफास्ट तिकडे तुझ्याकडे एक नंबर टेबल
I don't know if you can see 3D nicely. Is it 3D? I guess it is.
Put on your 3D glasses.
What's your name? Skandev. Nice to meet you. So we will try to see as many of these structures as possible. And for this kind of dissection, what we just need is a perfect specimen that I do believe the anatomy department created for us, and a wooden spatula, as simple as this, and a forceps. That's all what we need. So something important is to create a perfect spatula, and for that we can sharpen it a little bit. with a knife. So give me 1 minute to prepare that. And then I will try to show you how this sulcogyral pattern is arranged. We will start with the lateral aspect of the brain. This is a left hemisphere. Generally, you know, the dominant hemisphere is the left one, so we expect this specimen was dominant in the left side, and the speech tracts are usually thicker or bigger in the dominant hemisphere. That's why we chose the dominant one for this dissection. But who knows, maybe it was left-handed patient. We'll see. Do you know the fascicle for the second year medical students? Please help me to make it interactive. Does anyone know the name of the fascicle which is connecting Broca's and Wernicke's area? Arcuate, I heard, yes? That's it. So that's one of the first ones we will try to uncover. Okay, so let's start. Can you see 3D nicely? Yeah, I cannot. Now it's better for me. Okay. Can you stop the autofocus? Maybe that will. Okay, because I'm gonna place my hands there. Maybe the autofocus will get. Okay, perfect. Okay, so this is the lateral aspect of the left hemisphere, and the first important landmark we see is this fissure here. What's the name of this fissure? Louder. Sylvian fissure. Perfect, thank you. Or lateral fissure, also known as that. And if I split it and I open it a little bit, which is there? Insula. Insula means island. So it's an island lobe, which is hidden in the depth of this lateral fissure. Yeah? Good. Can I have a forceps? Ah, it's here. Yeah, thank you. So yesterday we were cleaning a little bit the hemisphere in order to have a nicer one. So we removed all the arachnoid and almost all the vessels. Yeah? So let's go to this lobe, which is the frontal lobe, and then behind the frontal lobe we have the parietal lobe. And in between the frontal and the parietal, let me tell you that we have something very important, which we call the central lobe, which for many anatomists we have a part of the frontal and a part of the parietal. Do you know the name of this gyrus? Louder.
Loudly, please.
Precentral gyrus, perfect. Primary motor area. And this one?
Post-central.
Post-central. So this is the central sulcus. Great. So frontal lobe, parietal lobe, and for functional terms, we like to call this one the central lobe, okay?
Yes.
Which is completely in a different direction. The frontal lobe is composed of 3 gyri.
Yes.
We can see it here. Superior,
Yes.
middle, and inferior. So you can see it's longitudinally oriented, but the central lobe is oriented in a transverse way. Yeah? So you can see how the superior frontal sulcus and the inferior frontal sulcus are ending in the precentral sulcus.
Yes.
Okay?
Yes.
Very important part of the frontal lobe is the inferior frontal gyrus,
Yes.
where we have something called operculi.
Yes.
Do you know what operculum means? Cover. It's covering the Sylvian fissure. So we have a fronto-orbital, fronto-parietal, and temporal operculi. So this operculi is like a mouth, is the lip. We have 2 lips, and they are covering or hiding the Sylvian fissure and the insular lobe. So starting from anterior to posterior, in this inferior frontal gyrus, we have what we call the pars orbitalis, which is called orbitalis because it's just above the orbit. We then have something called pars triangularis, which is indeed this triangular shaped structure.
Yes.
And finally, we have the
Pars opercularis.
pars opercularis, which is the so-called Broca's area,
Yes.
mainly. This is the speech, motor speech area. Very, very related to the most lateral part of the precentral gyrus. This is so-called ventral motor area, where we have mainly the neurons going to the pharyngeal muscles to produce the speech,
Yes.
right here.
Yes.
Okay, so let's go to the central lobe we already mentioned, and you can see now how it's differently oriented to this longitudinally oriented gyri in the frontal lobe, precentral, postcentral gyri, and central sulcus. And the central sulcus generally ends up in something called subcentral gyrus, which is the connection in between the precentral and the postcentral gyri. Generally, we can see this connection in the lateral aspect. 90% of the cases of the specimens have this connection right here, but in 10% of them, like this, it's hidden inside the fissure. You can see in this specimen, it was hidden. But there is almost always a connection in between the precentral and the postcentral gyri, the subcentral. And I will tell you some important landmark later on. Parietal, occipital, and temporal lobes. Do you know how we name these lobes and why we name these lobes like this? Because they are, the frontal lobe is in front of the frontal bone. The parietal is related to the parietal bone, occipital and temporal. But these are arbitrary divisions. So in order to have a common language, a common definition, what we do to define the parietal, occipital, and temporal lobes is we identify the most posterior part of the sylvian fissure, which is right here. This is the so-called posterior sylvian point. And we identify two more landmarks. You can see there is a notch here. You see? An inflection point. So this is the so-called tentorial notch. And if we go to the middle aspect of the hemisphere, we will see the parietoccipital sulcus. Okay, so this is our landmark. This is our landmark. And now we are tracing a line in between those landmarks. So what happens is that posteriorly, we have the occipital lobe. Okay, so the occipital lobe is nicely named right now. This is the occipital lobe. Tentorial notch and parietoccipital sulcus. But how we divide the temporal and parietal? So what we do is we trace a perpendicular line from this posterior sylvian point, and the point in which it's crossed with the line we traced before is marking the difference. So this is the temporal, and this is the parietal. This is so arbitrary definition that it doesn't perfectly fit for our definition of the gyra. You can see this gyrus is partially in the temporal and partially in the parietal lobe. So that's why we, as neurosurgeons, prefer to name the gyri, because the gyri are much more evident for us. Anyway, you need to know this concept. So that's on the lateral aspect. We cover the parietal, the occipital, and the temporal. Let's see the different gyri which are inside these lobes. So let's start with the parietal, which is this area here, just posterior to the postcentral. So we have a very important sulcus. Do you know the name of this sulcus? Which divides the parietal lobe in a superior and an inferior parietal lobe.
Intraparietal.
Intraparietal, thank you. So this intraparietal sulcus is connected, always connected with the postcentral sulcus. As you can see, this is the point where the intraparietal connects with the postcentral sulcus. So superiorly, we have the superior parietal lobe, very important in both hemispheres, but especially in the non-dominant. And inferiorly, we have two different gyri. Do you know the name of this gyrus? Say again? I cannot hear.
Supramarginal.
Supramarginal. And it's called supramarginal because it's just superior to the marginal branch of the sylvian fissure. So we have the sylvian fissure, and this is the marginal branch. So just superior to it, we have the supramarginal gyrus, which is the anterior part of the inferior parietal lobe. And now if we follow the superior temporal sulcus, we will have the same. We have an angular gyrus right there.
Yes.
You see? So supramarginal, angular, and superior parietal lobe. These are the three divisions of the parietal lobe in the lateral aspect. Okay. Let's go to the occipital lobe, which will be very easy to divide because it's a crazy lobe. The arrangement of the gyri here it's very, very difficult. So we mainly divide it in superior, middle, and inferior gyri. That's it. But the pattern is probably the most heterogeneous of all the lobes. Superior, middle, and inferior gyri of the occipital lobe. And the temporal lobe is very special. I will try to show you today because it's the only lobe which has 4 surfaces. The lateral one, which is the only one we can see now. So this is the superior temporal, middle temporal, and inferior temporal gyri, with a superior and an inferior temporal sulcus. But we also have a hidden surface, which is right there in the depth of the fissure. This is the superior surface of the temporal lobe, which is divided by this gyrus, very, very nice gyrus. Do you know the name of this gyrus? You know it, but anyone else knows the name? Thank you. Say again.
Louder, louder.
Please. Perfect. This is the transverse gyrus of Heschel. And do you know the function of this gyrus?
Facial.
Perfect. Perfect. Thank you. So this transverse gyrus of Heschel is coming from the depth of the fissure. If you see it there, can we zoom in a little bit?
Paresh, just zoom in.
Can we zoom in? Right there.
Go zoom, 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 zoom. Yeah.
Okay.
Focus. Focus it. Little more zoom in. Yeah.
Great. So the point in which this transverse gyrus is touching the insular surface is the so-called posterior insular point. And I will show it to you later. And if we enter and we cross that substance, we will reach the atrium of the ventricle. Okay? So this is a good landmark. In front of the transverse gyrus of Heschel, we have a flat surface of the temporal lobe. Can you see that flat surface?
Yes.
Do you know the name?
That surface.
It's called planum polare. Planum means flat, and polare is the pole, the most anterior part. So that's why it's called planum polare. These are very easy words for me because Spanish is a branch of Latin, so it's very, very simple for me to understand planum polare. And then posterior to the transverse gyrus, we have the planum temporale. That's it. These are the 3 different parts of the superior surface of the temporal lobe. And I told you that we have 4 surfaces because we have an inferior surface, which is mainly made of 2 gyri. The T3, which is part of the inferior temporal, and the fusiform, which is a very, 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 very strange shaped gyrus. And we have a medial aspect also, the 4th one, which is mainly made of this gyrus. Do you know the name of this gyrus? Maybe you can.
Louder.
What's the name of this gyrus? Parahippocampal, thank you, which is obscuring and covering the hippocampus, which is inside the ventricle, and we will see it later on. This parahippocampal gyrus and the fusiform gyrus is divided or separated. They are separated by this very important sulcus. Do you know the name of this sulcus? Collateral. Perfect. So if we enter the collateral, we cross this substance, what part of the brain we will be reaching? The temporal horn. So if we enter here, we will reach the floor of the temporal horn of the lateral ventricle in a point called the collateral eminence because it's connected to the collateral sulcus. Okay? So just giving you the names that we will be using later on. And anteriorly, this collateral sulcus has a kind of accessory branch, which is the so-called renal sulcus, which is separating this structure, this pyramidal structure. Do you know the name of this pyramidal structure? Ancus. And can you see a line here? Yes? What do you think this is? Do you know the tentorium? So the tentorium, in most of the cases, is creating this shape here because it's this uncus is on the tentorial incisura. So this part of the uncus is medial to the tentorial incisura, and we cannot see here the 3rd cranial nerve, but the 3rd cranial nerve is arising from there. So that's why when we have a huge mass or hematoma or swelling here in the lateral aspect, this uncus is pushed medially and is compressing the third motor nerve. Yeah? Oculomotor nerve. So the third cranial nerve. And what's the sign that we can see in a patient with an ankle herniation? What do you see?
Something with the pupil. What happens to the pupil?
And anisocoria. And this is a very bad sign. It means that the brainstem is at risk of compression. So the first thing we used to see is this anisocoria, because the third nerve is compressed by this ankle herniation. And the next step, if we don't do anything surgically, might be the compression of the brainstem, which is something vital. So this is an alarm sign. Whenever you see a patient with a brain damage and he's in comatose state and he has an anisocoria, you must do something fast. Okay. So that was about the temporal lobe. We covered also the parietal and the occipital lobes, and I think we should cover the medial aspect later on. So we could start with the dissection of the lateral hemisphere. And if you don't mind, I would like to show you a few slides. Can we go to the presentation? Just 5 slides, 2D. No, that's fine. Yeah. So this is the anatomy we have already been discussing. And the first step will consist on taking, you remember the word pallium, the cover? So we want to uncover the cerebral substance. So for that, we will uncover the U fibers. And this is a video, I don't know if it's working, let's see, in which we are showing the classic coronal picture you see. But now we can see our structures. These are the structures we want to cover. So if we work in the operculum and the operculi area, we will start uncovering the inferior frontal sulcus and the superior temporal sulcus. So then we will see the superior longitudinal fasciculus and the arcuate fascicle that you were pointing at before. So this is the dissection we want to do. We want to see this 2D picture from a 3D way. And how we do that? So we start like this. We will split the gyri in the superior temporal and inferior frontal sulci, and we will remove the cortex from the depth to the surface. So these are the first fibers we will be uncovering, the so-called U fibers connecting adjacent gyri. So then we will have a picture like this, because what we want to do is to do this C-shaped dissection of the cortex. Usually this part of the dissection is the most boring one, and it takes time, so I will try to do it as fast as possible, so please don't complain too much of my skills. So we want to do this uncovering of the U fibers in the temporal, parietal, and frontal side. And this is the anatomy we want to uncover. Do you remember these U fibers? So you can see how they are connecting adjacent gyri. And the next step will be dissecting the dorsal stream. You know we have a dorsal and a ventral stream, and we will cover that in a short time. So we can go to the dissection, and I'm gonna start, and that's focus enough. So I'm not gonna complete the whole thing because it will take too much time, but I just want to show you how we can do that. So we split the sulci and we go to the depth. It's very important to do it from the depth to the surface. So we just take out the gray matter. Can I have some water, please, here? Could I have water here? Here inside. So please let me know if you see properly what I'm doing. I'm just removing the pallium. You remember our neopallium, our neocortex? So trying to uncover the first layer of fibers, short association fibers. Let me thank again the anatomy department, because this is a beautiful, beautiful treated specimen. So it will make the journey much easier. So now it's up to me. I'm very stressed. So these are the U fibers. I don't know if you can perceive them there.
Can you just focus, please?
Thank you.
Hello, Paresh, yeah. Zoom in, yeah. And focus.
Let me say that this is the first time that I do this live, especially for such a large number of people. So I hope it works. And you can see now the U fibers there. So you can see how these fibers are connecting. You see? Superior temporal and medial temporal gyri. So again, we open the sulcus, and you can see the cortex, and it's closed right here, where I have my Boudin spatula. That's the cortex, and how it's connected to these U fibers. So we keep working on that on both sides of the gyri. This is boring, but very, very important stage on the dissection. So let me do it carefully, because I want to show you nicely the depth of them. So this is the depth of our superior temporal sulcus, and I'm just taking out the neocortex. You remember our neocortex? 6 layers of neurons. Something I didn't tell you, but it's very important, is that this subcentral gyrus is touching the point in which the anterior transverse gyrus is joining the superior temporal gyrus. And this is the most anterior aspect of the Wernicke's area. So when we are talking about a temporal lobectomy in the dominant hemisphere, if we don't have stimulation, we cannot do an awake surgery. This is a landmark which is giving us the most posterior safe limit of our resection. Because if we damage this area, probably we will have some speech problems. So we can identify this landmark in the junction of the subcentral with the temporal gyri. So again, another example of how important it is to know the anatomy and to analyze properly every single case. Generally, the success of a surgical procedure is taking much more time preparing it, studying it, than actually performing the case. And for that, what we have in our daily routine is MRI and CT scan. And the reason why you are studying the brain with 2D cuts is because you will see this MRI and CT scan in a 2D way. But nowadays we are very lucky to have tractography and to have 3D reconstructions, which is much, much easier to understand. So that's why this 3D dissection is, from my understanding, very important. As this is going to be a quite boring, this part, you feel free to ask anything so we can discuss while I dissect. Say again? I cannot hear, please.
The instrument which you are using.
This one?
Yes, this is
It's
a
a
wooden spatula.
Yeah, very, very cheap wooden spatula, which is fantastic. We don't operate with this. we have much more expensive devices, but this one is fantastic because being wooden is avoiding damaging too much the anatomy. So that's why we like this wooden spatula. It's a tongue depressor indeed. So I created my spatula with this tongue depressor. Okay. So generally, I should continue the dissection all around the sylvian fissure. Can we zoom out a little bit? Bit more. So my next purpose is to uncover the beginning of the dorsal stream. I don't know how many of you have heard about this. It's quite a neurosurgical term, dorsal and ventral streams. So let me tell you what it means. We have the sylvian fissure, and then we have the central core with the basal ganglia and internal capsule, which are mainly located in this area. So then we have association fiber systems, mainly related to speech and other association functions. Some of these fibers, most of them are association, all of them indeed are association. Some of them are dorsal to the central core, and some of them are ventral. So I will show you that in the depth, and we will start with the dorsal fibers, which are called the dorsal stream, because they are dorsal to the central core. Most of them are longitudinally oriented here and here, the ventral and dorsal streams, but we have one which has this shape, this hook shape, and this is very capricious. This is the arcuate fascicle connecting Wernicke with Broca, and this is the first one we will try to uncover. So for that, a good trick, let's see if it works, is going to T2, which is the middle temporal gyrus. We identify the posterior part of T2. We identify the marginal sulcus of the sylvian fissure with the supramarginal area. And then, do we have a knife? Yes, I have it here. What I'm doing, remember that slide in which I showed you that in the gyrus, the long association fiber systems are quite close to the EU fibers. So what I'm doing here is I'm just performing a cut on this gyri, and for that I should have done a better dissection, but for the lack of time and not to bore you too much, I will try to do it like this. So now I'm entering the gyrus. So I want to split those fibers. Can you zoom in now, please? Can you hold this? I don't know if you can see those fibers. Can you zoom in? Oh, sorry. I wanted to come earlier, but your crazy traffic didn't allow us. I'll prepare this a little bit. But I'm sure you can see now the difference between the cortex and the fibers. So I'm just pushing. I'm just following the anatomy. And this is what we do also in surgery. Follow the anatomy.
Pablo, that was because you didn't want me to pick you up.
No,
you
no,
said
no.
Send a resident.
You're right. But I enjoyed it. Okay. So now we are in a very important part of the dissection because we don't want to go deeper. Okay? We just want to stay in the next layer. So perceive that I'm just pushing the fibers, and these fibers are running up, you see? If you don't see that properly, please let me know, because I really need you to see this nicely.
Can you zoom in, please?
That is perfect. I am not creating this anatomy. It's there. So this is part of that white substance that you see in a 2D cut. But you see it's not 2D. So let's keep pushing gently. And now you will see that it's wrapping around. Let me do something before, please, so you can see it nicely. You see how it's curving? Say yes. Okay. Do you see the fibers?
Yes,
You
so
see
I
it?
hope the students are appreciating. Now, if you try to see this in the anatomy dissection hall, you will not be able to see it. So this is the advantage of 3D, where you can really understand the fibers, the way they are going, the way they are splaying, and that's the advantage of 3D.
So that is great. And again, this specimen is beautifully prepared. So you can see how these fibers are coming to T1 and T2, yeah? This is the distal part of the arcuate and the vertical component of the SLF. So now I really want to follow them to show you how they are running to Broca. Some connections are coming here, just for the illustration. Let me show you that we can. Do you have a non-teeth forceps?
must compliment our anatomy department for giving us a very superb specimen. Even Pablo is impressed
Yeah, I
by
am.
the specimen. So thank you, anatomy department.
So you see the fibers? So this is not yogurt. It's organized, very well organized. It's a tremendous machine, as I showed you during the many millions of years of evolution. These axons were created. So if you hold this, you can again follow your anatomy. You see? These are the connections of our brain. Okay, so let's continue to the parietal and frontal side. You can customize your wooden spatula. So now I'm going to the frontal side. And something very special is happening now. Do you see that it's difficult for me to continue? Okay, so we are reaching the subcortical area of the central lobe. Do you remember that we have association, commissural, and projection fibers? Yeah? So what kind of fibers we do mainly have here in the central and postcentral, precentral and postcentral? What kind of? Louder? Yes, but about commissural, projection, and association. So if you think about the motor and sensory fibers, these are connecting the cortex with the thalamus, spinal cord, and brainstem. So mainly projection fibers, which go like this, go down. But now I'm trying to follow an association fiber system, which goes like this. So we will have an intermingling of fibers following this and these directions. So that's why when we reach this point, some fibers will get broken, and I'm going to show you that. You see how some fibers are getting broken? This is the intermingling of the projection and association fibers. That is what I want to show you. This is the post-central. So we have descending and ascending fibers, mainly ascending fibers, sensory fibers, and deeper we have the association fibers. So even in DTI tractography, this area is very difficult to tract because of that intermingling of fibers. So that's why we have to be a bit more aggressive here in this dissection, because we see the crossing fibers. You see? That's the point. Projection and association. Can you see it? Thank you. Okay. So let's keep working on our dissection. Because I want to show you how these fibers are reaching Broca. You see? What a beautiful direction. And you see that some of them are running anteriorly? Yes? Those are the ones going to Broca. And the ones keeping the anteroposterior direction are part of what we know as SLF3, superior longitudinal fasciculus. But see how some of them are going to Broca. Those ones, right there. Okay, so let's take the subcentral out. This dissection done in a proper way takes something like 2 or 3 days. So sorry for being so fast and so dirty. But you can see now, let me clean it a little bit before I show you. Removing the cortex, so I show you all the fibers that we have been uncovering till now, because this is like an onion. So we go layer by layer. Okay. Can I have some water, please? Here? Yeah, can you open? Let me clean it. So I show you the 3 fiber systems that we have already reached. Okay. So keeping a clean field is also very important, not only in anatomy, but in surgery. So you can see nicely. Can you zoom out a little bit? Okay, so now we have part of our dorsal stream. Yeah? SLF, superior longitudinal, which is called superior longitudinal because it's really longitudinal and it's superior, which means that we will uncover an inferior one. I will show you later on. And the arcuate means hook, is hooking or wrapping around the posterior sylvian point. This was our supramarginal gyrus, which is pretty much involved on the speech also. Wernicke, Broca, and supramarginal. So you see fibers of the arcuate wrapping around and going, connecting Broca and Wernicke. Yes? Okay. And we also mentioned that in this point, precentral and postcentral, we have descending fibers. So these descending fibers are going like this. And our association fibers are running like that. So there is a crazy intermingling of fibers there. And to make it even more difficult, we have also commissural fibers from the corpus callosum. This is our corpus callosum, so it's spreading to the lateral aspect. So we have also commissural fibers there. So this and these are very important hotspots, especially this one, where I will show you not only the dorsal stream projection commissural fibers, but also the ventral stream crossing. So this is probably the most functional area of the human brain, and I will try to show you later on. Yeah? So let's keep with the dissection, and before that I would like to go to the presentation, if possible. Yeah? Okay, so to summarize what we did, U fibers, and I did it too fast, but if you have the chance to do this dissection, which I really recommend to you all to do it, or to try to do it, starting with the U fibers. Sorry, just to show you. Okay. U fibers in the superior temporal and inferior frontal. So we go. Okay. And this is the cut we did. Yeah, you remember? And we follow our fibers there. So what I did, to summarize, I just cut here, more or less there, and I tried to get this cleavage plane. So what I did with the spatula was to push the long association fiber system, to open it, yeah? And to see this beautiful vertical component of SLF and arcuate, which is the same one indeed, yeah? And the SLF, 3. We have 3 components of SLF, 3, 2, and 1. And in from an anatomical point of view, you cannot really differentiate them, and you see this is the limit of 1 and 2. You cannot see that. So dorsal stream, because it's dorsal to the central core. Okay, so we did that, and let me show you how we can take advantage of this anatomy in the OR. So this is a patient, this is the right hemisphere, but he was left-handed, so his speech functions were in the right hemisphere mainly. Could you tell me where, some of you, tell me in which area of the brain is this glioma? Which lobe? Central lobe. Which lobe? Lobe. Frontal. Frontal. Yes, it's frontal lobe. Why? If we go to the axial cut, we see our precentral gyrus just here. It's pushing the precentral gyrus. So if it's pushing the precentral gyrus, and from the coronal perspective, in which three of the components of the frontal lobe it's located? In which gyrus? You go to the coronal now. You remember we have the... Which gyrus is this one? Superior. So this is the inferior frontal gyrus. And remember we had three components of the inferior frontal gyrus. From anterior to posterior, we had the pars orbitalis, triangularis, and opercularis. So it is a pars opercularis glioma in the dominant hemisphere of this patient. So what you are scared about? Speech. Which fascicle is connecting this with Wernicke? We just saw it. Arcuate. So we have some wonderful tools, which is the tractography, where we can see and we can track our arcuate. So you can see it's pushed medially, and luckily, the speech area, Broca's area, is a bit anterior. So this low-grade glioma was probably pushing the function anteriorly. Yeah? But the challenge is that we have the arcuate in the depth, and anteriorly, based on the functional MRI, which is not the gold standard, we have our speech area anterior to the tumor. And what is in red? You remember those fibers that we were dissecting right now? What is this? Projection fiber. So this is the hot spot I showed you, where you have the corticospinal tract going down and the arcuate running anteroposteriorly. So these are fibers that we could map if we have the chance to do so. I do few awake surgeries, and this is the very real case in my environment for an awake surgery, if the patient is able to go for that. So this is what we do. We do a classic speech test with the patient. So we train the patient a few days before, and this is the kind of tests we will be doing with him, so mainly a speech and motor tests. And we train him because he's going to be in a difficult situation during surgery, so he really needs to be part of the team. Indeed, he's the most important guy in the team that day. So this is what we expose once we open the dura. And this is what I told you. We have these 2D pictures, which we need to understand, but the 3D reconstructions are now being very helpful. So just to show you and to make you understand what I'm doing here, this is the right side, this is the frontal lobe, this is the precentral and pars opercularis tumor located there, precentral and pars opercularis. So this is precentral, postcentral, parietal lobe, which is posterior to the tumor, and now you can see it much better than in the 2D cut. And this is the Sylvian fissure. Yeah, you are all oriented? So T1 and T2, and this is how we want to find the patient in the OR. And this is our craniotomy. So now the next point is, you have studied and planned your anatomical planning of this patient. You have all the areas that you want to check and you want to find, but this is the picture you get in your OR. So you have to translate and to move from 2D to 3D planning to the intraoperative view. And this process can only be done properly if you do this dissection and you know your anatomy, okay? So we want to check, especially this area. Remember, in the functional MRI, we had a speech there. So this is the first thing we will check with him. We are going to, first of all, to the sensory and motor to check the intensity. We are using the threshold. That's very important, the first thing we do. So once we have the threshold and we have this tapping test arrest, we know which threshold we can use, and we found function in this anterior part. So this is why I'm covering this with a cotonoid. This is very relevant for speech. So then we start our dissection, subpial dissection, and the problem of the surgery is that we don't see these fibers. We just see a white substance. So we have to imagine where they are. And we have the DTI, the functional MRI, we have the echo, intraoperative echo. We don't see the fibers in any of these. So your mental imagination is very important at this stage. So we just go deep, and the patient is awake in this part of the surgery. So as we go deep, we are mainly working with something called ultrasonic aspirator, which lets you destroying the tissue gently and sucking it. And we do it layer by layer. And the beauty of it is that we can even connect monopolar stimulation on its tip. So while we are going deep and deep, we are doing subcortical stimulation. So we can have what we call speech arrest, because this is the area we will be reaching in the depth. This yellow thing, which was the arcuate, should be there. So we start our stimulation in that area. And the moment in which the patient has a speech arrest, we stop the surgery. And this is the post-op, where you can see that there is some tumor remaining, but it's mainly located in the arcuate and in the Broca's area. And this is something that we don't want to damage with a low-grade glioma. So this is the post-op image, and this is the part of the tumor we were able to remove. And thanks to the intraoperative monitoring and our knowledge, we are able to preserve Broca and arcuate. So this is an example of how we can squeeze this knowledge and move it to our clinical practice. I hope it made sense. So we continue. Should we continue, Vernon? Yeah?
Yes, Pablo, go ahead.
Many people are sleeping already? Not many? You all awake? If you get bored at some point, let me know, and we can go to some nice slides or discuss something, whatever. Please make it interactive, otherwise it will be too tough for me. Okay, so uncovering the insula. We have work on the operculi, temporal, frontoparietal, and frontoorbital. Yeah, remember. So now, to uncover the insular surface, what I'm going to do is a cut of these operculi. So I will remove them to go deep. Okay, so thanks to this dissection, now we can split the sylvian fissure much more efficiently. We can take some of the arachnoid that we were not watching. And before cutting that, I want to show you something that generally we don't pay attention to. This is brain. We cannot see it, but it's there. This is what we call the subopercular surface of the frontoparietal, frontoorbital, and temporal. But it's there, and we should consider that sometimes we have also functions in those subopercular areas. So this is the supramarginal. This was the supramarginal gyrus that I'm removing now. And let me show you much better the arcuate. So now I'm going to follow the arcuate and uncover it much better. Can you see the fibers, how they are? I'm just taking them. Follow these fibers. Okay. So again, as in our case, our tumor was located in this area of the brain. So we had the, let me show you in the anatomical view. The tumor was located here, and this was our functional limit, our arcuate. So this is how deep we were able to reach. We couldn't reach a deeper aspect. So let's continue removing the operculi. And I am uncovering the insula. Okay, so now we have the frontal lobe, and we are uncovering the superior aspect of the insula. Do you see those vessels? These are deep perforators, branches, deep branches of the MCA. Vernon, should I stop? Okay. 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 So this is again something too fast. Usually it's much better to dissect everything. So go layer by layer. But now for time reasons, I'm speeding up. So here you can see our hidden lobe, our insula. Yeah? We remove the fronto-orbital and fronto-parietal operculi, so you see the relationship of the arc weight and SLF. Okay. Remember your transverse gyrus? Now you can see it much better. Your transverse gyrus of Heschel with the Wernicke's area, and how this gyrus is directly coming from the posterior insular point. We have 3 points. The insula should be understood as a pyramid. You can see it now in 3D, so this pyramidal concept makes sense. This is our apex. This is the most superficial point of our pyramid. And we have a superior, inferior, and anterior aspect. And this superior, inferior, and anterior aspect of our pyramid are related to the 3 important sulci of the insula: superior periinsular, inferior periinsular, and anterior periinsular. So these 3 sulci define 3 important anatomical landmarks: anterior insular point, which is the junction of the superior and anterior sulci, and if we cross this, we will reach what part of the ventricle? Say that. Frontal horn. If we go deep here, we will reach the frontal horn. Posterior insular point, the junction of the inferior and superior, the junction of the transverse gyrus to the insula. If we cross here, which part of the atrium? Perfect. And finally, we have the junction of the anterior and the inferior, which is this area here. Does anyone know the name of this area? This is the limen of the insula. Yeah? Have you ever heard about that? Good. I lost my spatula. Can you help me? It's there in the floor. So let me take these insular veins so as to make it cleaner, and you can see the limen of the insula. Do you remember the story I told you about the paleopallium? So this is paleopallium. We only have 2 or 3 layers of neurons, very rudimentary cortex, mainly related to emotions, fear reactions, and olfaction. Okay, so now, as we have already studied the superior surface of the temporal lobe, remember the planum. What's the name of this? Planum polare, transverse gyrus, and planum temporale. So do you allow me to cut it? Yes, thank you. So let's cut it. But there is a rule in this dissection. You can only cut something if you know what it is. So I'm just trying to cut at the level of the inferior peninsular sulcus. Okay.
Pablo?
Yes? It's done?
Yeah. If we can take a break for
Please,
few
I need
minutes.
it.
Yeah. Thank you. Thank you. And for the students, I hope
Thank you.
you all have understood. And if you all need to ask anything, you all can directly stop us and ask. No problem. Our Dean ma'am is here, so we will have a small address by her, and then we will continue. Can we have the chairs, please, and the lights on? Lights on, lights on. Vikram, come in front.
सभी जो भी है ओके स्टाफ लोगों को किसको बोलेंगे पहले टीम में
Lights on, please. I would request all the dignitaries on the dais, please. Joshi, sir. So we'll be having a short inauguration function of this cadaveric dissection. So first I would like to welcome our Honorable Dean Madam, Dr. Pallavi Saple Madam. Bouquet. Madam, thank you, ma'am, for helping us organize this function. I'd like to welcome Professor Dr. VERNON VELHO, sir, who's first I would like to welcome Dr. Palande, sir. He's our ex-professor of head of department. He was my unit chief when I joined the department. So, Professor Netalkar, sir. Next, I would like to welcome Dr. Dev Pujari, sir, who is head of department at Bombay Hospital. And finally, our guest of honor, Dr. Pablo Gonzalez. So he has been very, has mesmerized with his cadaver dissection. So without the help of support of Dr. Deepak Joshi, this would not have been possible. So I'd like to invite Dr. Deepak Joshi, sir. Who is head of department of anatomy at JJ Hospital, and Dr. Adil Chagla, sir, for gracing this occasion. He is head of department from KM Hospital, Mumbai. So I'd now request Dr. VERNON VELHO, sir, to say a few words.
Thank you, dear friends, dear students. And on behalf of the Department of Neurosurgery and Department of Anatomy, Grant Medical College and Sir JJ Group of Hospitals, I welcome you all to this spectacular event, which is something different, especially for our students. For us, it is common. And first and foremost, I like to thank our dean for giving us all the permissions. And I keep, pressurized. I keep harassing her for all these things, and she says, okay, you just do it. So every time we go to the dean's chamber, we say, Madam, we want to do this. Madam, we want to do that. And she's ever ready to help us and give us this support. So thank you, ma'am. And sorry for troubling you so much. That's and of course, I'd like to thank my Professor Joshi, because without him, we cannot do these workshops. It's very difficult. And we are the people who harass him also. At least twice or thrice in a year, we harass him for some cadaveric workshops. I'm thankful to Professor Dev Pujari and Dr. Netalkar. They are from Bombay Hospital and GNS, whom we are doing this as a joint organization, and they are also helping us in doing this. And also my mentor, Professor Palande, who's always there. He cancels all his programs, and if it's a JJ and a Grant Medical program, he has even cancelled going for his own relatives' weddings, and he comes here. So thank you, sir, for being here. And my friend Pablo, who's always here, He was supposed to be here in 2018, but because of some visa problems, he could not come. And then he told me that, I promised you I'll come here, I'll teach the students, and he has been here, and he has a very hectic schedule. He's going tomorrow to Nagpur, from Nagpur he's going to Manipal, and he's going to do the same teaching there for 3 days. So I've already introduced Professor Pablo to you. He's a great anatomist and a great neurosurgeon, and he's young blood, so he enjoys teaching. He enjoys teaching young people. And of course, Professor Adil is here. He's the head of neurosurgery at the KEM. He's also a Chakaraka. He's the GM side, hardcore GM side, okay? And welcome. And thank you all. There are many neurosurgeons who have come. There are many post-MCH neurosurgeons. I see many of my ex-students here, and it has been a house full pack. There's no place to sit, and I'm worried. I don't know whether I've catered for so many, but you're going to get food. Don't worry. Thank you. Thank you.
I would request Dr. Dev Pujari sir to say a few words.
I must thank the Dean, Vernon, for this platform and to hold this wonderful workshop today. And I must thank Pablo. We were hoping that we can engage him for quite some time, but I think time-wise he didn't have any, and we also found that it was a little difficult during the week because he's just coming out of one meeting and going for another workshop from here. But more than 2 decades ago, when I did my first fiber dissection workshop with Professor Yasar Gill, and you must understand, we didn't even realize the surgical importance of it at that time. We were just learning because tractography wasn't available. And only after the tractography became available, we understood the clinical and surgical importance of it and how important it has become to neurosurgeons. And Yugo Ture and Yasar Gill have been mentors for Pablo, and he has now recently been elevated to the academic unit which gives him access to anatomy as well as neurosurgery departments in Alicante. And he's created a wonderful lab in there, as many of you can see on his 3D website. And you can even visit him. I've had a chance to interact with him on a few workshops in India and abroad earlier, but this is the first time we could host him in Mumbai, and I hope that there are going to be future workshops to take us to the further depths of brain. So thank you, Pablo, thank you, Vernon, and thank you all the GMC Dean as well as the staff for making this possible. Thank you.
I'd request Dr. Pablo Gonzalez to say. Palande sir, please.
All the students, dignitaries on the stage, Madam Dean, Madam, Professor Paolo, all my colleagues and friends. Dr. Dev Pujari is also our student of the Grand Medical College Neurosurgery Department. Dr. Chagla was the captain of our cricket team when he was doing his as a GM site. Later on, he went to do his neurosurgery somewhere else and then took a post in KM Hospital as a faculty. Now he is the head of the department. I think Dr. Vernon has done a great job today in organizing this kind of a workshop and especially involving all of you, the students, because all this time we have been doing workshops, only our postgraduate students were involved. I think this is the first time we are having all our MBBS students watching this kind of a thing of neurosurgery, and I hope it will impress all of you, because at this stage when you get impressed, I think you make up your mind, as he was rightly telling in the morning. So I hope all of you learn the brain properly, because ultimately it is the brain which controls the whole body. So, and when I was the student and the faculty and the HOD, Till that time, we had only neurosurgery at JJ Hospital. Now it has been developed at Pune, Nagpur, and some other places. But then we used to always say that fourth floor is the brain and heart of Maharashtra. So I won't take much of your time because we would also like to see the further dissection which Dr. Paolo is showing. And I was also very much impressed with the way you are showing this, with correlating the anatomy with the model and the actual brain. Because I was discussing with Netalkar that they might think that actually when we are operating it is so simple. Now that you showed the actual brain while operating how it is, and you can't make out anything there, it is as he says, we have to use our imagination to know where the fibers are and all these things. So thank you, Dr. Vernon, and thank you for upgrading the department to this extent now that we are able to do all these things. Thank you.
Thank you, sir. I would request Dr. Pablo Gonzalez to say a few words.
I don't want to bore you more. I'm talking too much, so I need to save some energy. And I just can be thankful to all of you for giving me this opportunity, because it's, you know, preparing this, it's helping me to learn, to review my cases, to study again. So I'm taking advantage of that. And I really thank you so much for being here. And I hope to be at the height you have created. Thank you. Thank you.
I'd like to give a token of appreciation as a memento to our guest of chief invited guest faculty, to Dr. Pablo Gonzalez. I would request Pallavi Saple ma'am to share the honors. I'd like to request Dr. Palande sir. I'd like to request Dr. Vernon VELHO sir to give a memento to Palande sir. Request Vernon sir to hand over memento to Dr. Dev Pujari sir. To Dr. Adil Chagla sir. Yeah. Request Vernon sir to hand over memento to Deepak Joshi sir. To Dr. Netalkar sir. Now I request our Honorable Dean ma'am to say a few words.
A very good morning to everybody who's gathered here for the fiber dissection. As I was just talking to Dr. Vernon, and I was wondering, why do neurosurgeons need to attend? He said, one, of course, we need to revise, which of course is the norm for any clinician. But he said fiber dissection is something unique and doesn't happen very often. And he's roped in Dr. Pablo between assignments, but because he made a promise to come, and that's why he's been here. This is also the first time that I remember I'm attending a workshop where an undergrad who is just in his first year, and renowned neurosurgeons who've been operating on brains for decades are sharing one forum, so to say, and everybody feels that they're going to go back with something. So that's truly a unique and a wonderful thought that has come through. I would like to compliment Dr. Vernon. Here I'm speaking as an administrator. So a few things that need to be said is, one, he's not forgotten his mentors. Otherwise, as an administrator, let me share, this is not so much relevant for students, except that you need to understand that teachers have to stay teachers for life. I've had senior faculty actually come to my office for pension-related issues, for minor issues, and here is somebody who never ceases to use the chance to sort of felicitate or to honor his mentors. This is something that, although he's not a GM site, it's a proud tradition that he's learned to carry on. I have never met Dr. Netalkar before, but I think he must be feeling left out because everybody else seems to be a GM site. And me being a GM site, I'm frightfully proud of that fact. Just remember, just yesterday we have an alumni WhatsApp group, just to share with you. And there was, probably it was Dr. Jivraj Mehta's anniversary, or I don't know. But there was a discussion which just cropped up. And those of you who are from KEM know that there's an auditorium, which is the Jivraj Mehta Auditorium. And he was the first Chief Minister of Gujarat. But then we also know that he was a GM site who founded KEM. So anything that KEM does, we get the credit. I also realized that during conferences, speeches are mandatory, but they should be kept short. And the little bit that I attended in the dissection took me back to the anatomy hall. And there have been a lot of interaction between the Department of Neurosurgery and Anatomy that I have seen personally. And I have been told that there's a concept called as a cadaveric lab, which apparently costs a lot. But I'm going to get Dr. Vernon and Dr. Joshi to help me set up something like that, because that would invite international delegates, is what I'm given to understand, and that is where I see this institute going back to its glory days. Just in the past few days, a lot of media coverage was given to the fact that Hafkin devised his plague vaccine in this campus. So we want to go back to that, not reinventing the circle, so to say, but doing new and wonderful things. And again, I would like to compliment Dr. Vernon, and believe me, I'm a very good administrator in that respect. He says he keeps on nagging me, but you don't know what I've dumped on him. No neurosurgeon has ever taken on very many administrative duties. A little bit Dr. Palande did do so, because they would always say that they are in the operating room for over 10 hours, 15 hours, which is a fact. But yet, I have managed to bulldoze him into taking up the warden's post, and he's doing a wonderful job of that as well. So again, my best wishes to all of you, and I hope we have many such interactive activities happening. Thank you very much.
I would request Dr. Palande sir to hand over a memento to Dr. Pallavi Saple. So we will carry on with the dissection. Thank you all the dignitaries on the dais for gracing the occasion. We'll be moving ahead with the dissection. Srijit.
I continue.
Lights
Continue
off,
with the
please.
section.
Those who want to have breakfast can go at the back end of the stage,
Yeah. I want breakfast.
outside.
Can I go?
Yeah.
Coffee is welcome. Thank you.
Those who are hungry can have a quick bite and come. The dissection will not stop because Professor Pablo has a few hours with us. We should make the maximum of it. He has a flight to catch for Nagpur. So please be quick.
We,
Okay, so for those of you who will continue with the breakfast of the insula, we were talking about the landmarks of the insula, and I will show you later on a sagittal cut on an MRI, and we will try to correlate this anatomy I'm showing you right now with this MRI. So just to summarize again, superior perinsular, anterior perinsular, which is the deeper one, and inferior perinsular. Anterior Sylvian insular point related to the frontal horn, posterior insular point related to the atrium. Are we recording, by the way? Yeah. And Limen insula, which is the junction of the anterior and inferior perinsular, okay? So remember I told you that here we have this story I told you about the paleopallium. So we have a very thin pallium here, only 1 or 2 layers of neurons. We have archipallium, mostly in this area, and finally in the most distal part we have neocortex. So different layers of neurons. And during the dissection, if you do it with a microscope, you can even perceive that as you are getting close to the Limen insula, the cortex is quite thin and it's quite attached to the subcortical structures. So to continue with the dissection, I mentioned we have an apex of this pyramid, and behind the apex we have a sulcus, which is the central sulcus of the insula, which indeed continues with the central sulcus of the telencephalum. So you can see, and it's the direction is here. Central sulcus of the insula, central sulcus of the hemisphere. So this central sulcus of the insula is dividing the insula in anterior and posterior insular lobes. In the anterior, we have mainly short gyri, 1, 2, 3, 4, and the accessory, which is always hidden, 5 short gyri in this specimen. In the posterior to the central sulcus, thank you, we have the long gyri, anterior and posterior one. And in this case, the anterior one has 2 branches. Yeah, but central sulcus, short gyri, don't forget the accessory gyrus, and posterior, we have the posterior long and anterior long gyri. Okay? So now let's continue with the dissection of the white matter, and let me ask you who could tell me the name of the first fascicle that we will uncover. Once I remove the cortex of the insula, what will I be uncovering? Think on the coronal cut. Think on a coronal cut. Yes, please. Hi. Extreme capsule. So now we are going to find, thank you, 3 capsules, and they are called capsules because they are encapsulating the basal ganglia. And the extreme means the more lateral one. We have 3 capsules, extreme, external, and internal. The extreme capsule is an association fiber system between the gyri of the insula themselves and also connecting the insula with the subopercular space. You remember we cut the subopercular anatomy, So this extreme capsule is also connecting the insula with these subopercular areas, association fiber system. And the external and internal capsules, which are really, really encapsulating the basal ganglia, are projection fiber systems. And I will show you. So let's start with the dissection and removal of the cortex of the insula. And for that, the technique is the same. Can you zoom in, please? So we do exactly the same thing. We start removing our cortex from the depth to the surface. And now the dissection is becoming more exciting because we will be uncovering very, very important structures. So again, the technique, you carefully detach the cortex, and now here you can see in this magnified view, again, thank you for the Ascolab, guys, this is a fantastic exoscope. You can see the cortex, you see, and the white matter. You see? This cannot be seen with another microscopes or exoscopes. So this is really, really fantastic. So now I'm uncovering the extreme capsule. And for that, usually I work, if you allow me, I usually work with a smaller wooden spatula, so I'm going to cut it a little bit, so I sharpen it. Each stage of the dissection needs a different technique, and here as the sulci are a bit smaller, we need something adapted to this anatomy. Okay, so now again removing the cortex and uncovering the extreme capsule. I will not feel bad if you need a coffee, huh? Please. This will take something like 4 or 5 minutes. So here, as I'm moving to the lumen of the insula, the neocortex becomes archy and paleocortex. You can see how this spongy aspect of the gray matter is nicely detached. And now you can start seeing how this extreme capsule is connecting, it was connecting the subopercular gyri with the insula itself. You see this curve? So as I move downwards and ventrally, the cortex, as I'm telling you, is a bit more difficult to remove. It's more attached, and it's, let's say, less organized. The functions of the insula are not very well understood, but in this area we are approaching the olfactory regions, and an important structure which I will try to show you later on, which is the amygdala, which is very close to the lumen of the insula. Indeed, in the past, and sometimes still yet, we are using the lumen insula to approach the amygdala. So keep working on this cortex. This must be gently done because the extreme capsule is quite thin, and we don't want to uncover the next layer. Every step of this dissection is very important, but especially as we get deep, the structures are thinner and thinner, so that's why it's even more important to be careful not to damage your anatomy, so you can see it nicely. Something I'm uncovering here, you see this black thing? Yeah? What is that? It's a vessel. Do you know the name of these vessels that we will start uncovering? Someone can tell me the name of these arteries? Yes, so this is the insula, and I'm watching a vessel here, which looked like to come from inferior to superior, this one. Okay. It's a branch of the middle cerebral artery, you are right, and they have a name. They are called lenticulostriate arteries. These arteries, from the MCA bifurcation, they penetrate something called anterior perforative substance, which is right there. Do you see some holes there? That's the anterior perforative substance. So they cross that area and they reach the subinsular space. Generally, they are more medial. They are located in the putamen, but this one is quite lateral, and they are important because some of them are feeding the internal capsule. So that's why damaging them could cause an infarct. And I will show you a case in which we had an infarct in the internal capsule because of damaging one of these lenticulostriate arteries, which is not nice, but it's something that we have to learn. And whenever you have a complication, and we had a complications meeting last weekend, you really learn so many points from your mistakes. Okay, so I keep working on this gray matter. Allow me to be a bit more fast. You see I'm leaving the lumen insula for the end. And here we see something nice. This is the so-called insular vein, which is almost always running there in the inferior peninsular sulcus. And it's draining the blood of the insula. Okay, so now I'm partially removing the transverse gyrus of facial cortex. So I'm keeping this hot spot for the end of the dissection because I want to show you how many fibers are there. Posterior insular point, it's clean, so the extreme capsule is nicely visualized. So let's work on the anterior long gyrus. And I'm uncovering now superior peninsular sulcus, just below the arcuate and SLF. So you see the very close relationship of all these structures. So again, that's why dealing with gliomas or tumors in the insula are so delicate, because they are really surrounded by very relevant structures. Thus, Vernon and Professor De Puchari just mentioned, the tractography has added a lot of information to our clinical practice, and it's helping us so much to design the kind of surgery we want to do. Okay, let me clean it a little bit. Okay. Okay, so the extreme capsule, it's appearing. Still some cortex here. I'm getting some fibers. And I am uncovering already the next capsule. What's the name of the next one? External capsule. So you see the difference? These are more wider and projected superiorly. I'm going to take the extreme capsule. Just want to show you that I'm not creating the anatomy, I'm just following the anatomy. Yeah, so you see this curved direction? This extreme capsule is connecting the insula with the subopercular surface. So I'm taking part of the extreme capsule to show you this direction. Coming to me, you see? Please keep this in mind, this shape, as it's connecting just below the arcuate, the subopercular surface with the insula. Keep that because I will show you a clinical scenario in which we can follow how a glioma is using this as a pathway. And finally, gliomas are following this. So they are performing this dissection by themselves. They're just following these fibers. So removing here, a bit more, the extreme capsule completely. Again, this shape, yeah? So the external capsule starts appearing. And remember, they are named capsules because they are encapsulating the basal ganglia. So now try to go to your mental idea of that coronal cut in which we see this anatomy, because complementing the 2D with the 3D is very, very important. Textbooks are 2D, but our brain works on 3D. Okay, even here, the extreme capsule is connected to the fronto-orbital operculi. Okay, so partially the extreme capsule being removed. So let's go a bit deeper. And the next step is quite important, because we will be uncovering also a very thin layer of gray matter here. Does anyone know the name? Claustrum. Yes, someone said that. Good. The claustrum is very thin. Sometimes we cannot even dissect it. But before going that, let me show you a clinical scenario in which we can take advantage of this anatomy. So if we can go to the presentation, if you don't mind. Can we? Can we go, sorry, to the presentation? It's just a very fast case. So we were uncovering the insula. And this is the anatomy we showed. So we have, again, what's the name of this fascicle? SLF3, great. This one, arcuate. What's the name of this sulcus? Superior peninsular. This is the inferior peninsular, and this is the anterior peninsular, great. So which gyrus is this? Transverse gyrus of Heschel, great. So central sulcus of the insula, anterior lobe, posterior lobe, short gyri, long gyri. Good. This is a detail of the arcuate, yeah? And this is the so-called hotspot, yeah? We have the arcuate, SLF3, and we will see many other ones. So another clinical scenario in which we can see a tumor. Which lobe? Which side? Left or right? Left. Which lobe? Louder? Parietal. Good. And I know you need much more cuts, but in which part of the parietal? Superior or inferior? Inferior. Great. Very close to the posterior sylvian point. So which part of the inferior? You remember that gyrus, which was that above the marginal ramus? Supramarginal. So it's a supramarginal GVM. So exactly in this area here. Marginal ramus, so this tumor was growing here. Parietal lobe. So you know anatomy, I'm very happy. So this is the exposure of the tumor. We are doing some fluorescence, so we can see that the tumor is there, and we found some response right there, but not on the tumor itself. So one of the mistakes in this case is that I didn't expose enough inferiorly, so this is the ramus, supramarginal ramus of the insula, of the sylvian fissure, sorry, and this is the angular artery. So we created a small window because we want to respect this part, which was highly functional, and then taking advantage of that, we have the functional region, and we have the cortical unit in which this tumor was. We don't have volume, I guess. But before surgery, he was not able, he had something called anomia. He was not able to pronounce this word. We were showing him this picture, which is a screwdriver, it's destornillador in Spanish, and he was able to explain what it is used for, but he was not able to name it. And just 3 hours after surgery, I was showing him the picture and he was saying, this is a screwdriver. What do you mean? So that was because the arcuate was severely compressed. It was not affected, but it was compressed by the tumor. So once releasing the mass effect, he was able to name it properly. Okay, and this is the anatomy we have already reviewed and uncovered. And let me show you another clinical scenario. Which lobe do you think this tumor is in? Insula. That's very clear. And this is the classic purely insular glioma. We have some operculo-insular gliomas which invade not only the insula but also the adjacent operculi. And this, despite the fact that it looks like big, it's not invading the operculi. So it's not using the extreme capsule to invade the operculi. So this is the right hemisphere where we can see the anatomy we just showed. Which is the sulcus? Superior peninsular, inferior, and fantastic. This is the anterior lobe, posterior lobe. So you can see now in the pathological side the same anatomy. Inferior, superior, anterior, and how the posterior lobe of the insula is free of tumor. So it's a purely anterior lobe of the insular glioma. So it's in the dominant hemisphere. We can do two things. We can do transopercular or transsylvian. Generally, by the fact that the transsylvian looks scary, this tumor has opened the sylvian fissure for you. You see in the right side, you have to split the sylvian fissure, but not here. The tumor has opened the fissure for you. So just cutting the arachnoid, you will be right in the tumor itself. So that's why I prefer, in these cases, to do that. And what kind of insular tumors we have? Purely insular, frontoorbital and insular, so operculo-insular, temporometial, temporal pole and insular, operculo-insular, and using this operculo-insular through the uncinate fascicle that I will show you right now, invading the frontoorbital, gyri, and the temporal pole. So these are probably the most complex ones because we have to do two transopercular approaches and we have very important structures there. So this is the tumor we have, and again, we have 2D pictures, but now we have a good mental imagination, so we can understand what is the yellow fascicle. Arcuate, fantastic. What about this green one? Going down. What is this? Which capsule is this? This is the internal. It's just internal to the putamen. We didn't uncover it yet. So this is the internal capsule, corticospinal tract. The external capsule is where the tumor indeed is growing. So that's our limit. It's not invading the putamen. The putamen, if you pay attention, is just pushed medially. And this is the caudate. So it's just lateral to the putamen. So this green spot is the corticospinal tract. And let me show you here, you will understand much better. Let's go to the healthy side, sylvian fissure, insular surface. Remember the subopercular area, extreme capsule, and external capsule in white, much more white, yes? And this is the, what is this? Louder, please. Putamen, perfect. Globus pallidus is a bit more medial. And what is this? Caudate. And in between the putamen and caudate, what do we have? Internal capsule, right here. Corticospinal tract, putamen, head of the caudate, and internal capsule going down. So you see the same anatomy. And even here you can see the arcuate and some optic gradations and IFOF. I will show you right now. Dorsal stream, ventral stream, capsule. So this is the crazy anatomy we have there, and we will try to uncover right now. So yes, we have a nice picture in our mind. So what we want to do in a case like this, is to try to respect this, and these fibers. So you can do a transopercular, but you will put at risk these fibers in this case. So that's why, as the tumor has been splitting the fissure for you, you will be able to do a transsylvian one. So this is the exposure, just to orient yourselves, especially the students. Here we have the left hemisphere. We did what we call a pterional approach. This is our sylvian fissure, yeah? So this is which lobe? Frontal. And this one is the? So F2, F3, T1, T2, sylvian fissure, supramarginal, okay? And this sylvian fissure is completely open. And let me show you and prove it to you. We do the ultrasound to make sure our limits, and then with the knife, we are just opening a little bit the arachnoid. No need to go too deep to see the tumor. You will see this is the sylvian vein. So we split the superficial part of the sylvian fissure, and this is the tumor already. It's there, you see? It's just there. So you can mobilize your veins towards the temporal or frontal. You cover the operculi because they are very relevant. And then you start doing what we call debulking. And you might be scary of the MCA branches, which you should very be careful of, but they are not inside the tumor. They are in the sulci, because this is a low grade. So you see, you can move them, and whenever I show one of them, I just try to cover it with a collagen, very thin collagen band, and I use some nimodipine, which is a medication which helps us avoiding the vasospasm. So then we move posteriorly to the delicate area and deep, where the corticospinal tract will start appearing under our subcortical stimulation. And in this point, we had some motor response at 3-4 milliamps, which means that this white matter is very close to the corticospinal tract. We know there is some tumor there, but again, low-grade glioma, we want our patients to be happy and good quality of life, and in case we leave a small remnant, this is much better in my mind than to cause a severe deficit. So I was scared to take this part here, where we have response of the corticospinal tract. Maybe looking at this, we could have been more aggressive, but the direction of our instruments was not very comfortable in that area. And it's now 5 years after follow-up, and she's doing great. Probably this tumor will regrow, but we are ready to take it out in case we need to do so. So that's how we can take advantage, again, of the anatomy. I hope it was well proven. And this is the extreme capsule we have already seen. And the next layer, and before going that, sorry, let me show you this dissection in which I'm really showing you how the extreme capsule is connecting also the insula with the subopercular space. You see? This is the shape I was showing you before. And this is a tumor which was biopsied twice, and it was growing and growing. And I want to show this one to you because you can see what Professor Yasarhil was mentioning, how these tumors grow through the highways. So you see, at the beginning it was a peropercular, the insula was pushed inferiorly and medially. Now you can see a small tail going in, and finally the tail which is invading completely the insula. Which capsule is it using to grow? Which capsule connects the subopercular space with the insula? Extreme capsule. So you can see how the tumors are growing through these highways. And the tumor, the surgery does not have any mystery. Again, corticospinal tract, this is something we want to be careful of. And something curious in this case is that despite the fact that in number 2, we knew that there was tumor here, there is tumor here, and this happens in low-grade gliomas, we had motor response. So we knew from the beginning that this was going to be a subtotal resection because we have a strong motor response right here. We know it's tumor, but sometimes low-grade gliomas have this behavior. Nothing very special, so let's continue with the dissection to go deeper. And this is the next thing I want to uncover. Which are these fibers spreading out? This is part of the corona radiata. Yes, it's a part of it, but it's the external capsule. The corona radiata indeed is the junction of the external and the internal capsules. So this is the next layer, this is the external capsule, and in this point, I will show you, we will have the junction of the external with the internal capsules. So that's the beginning of the corona radiata itself. And if we open some windows through the external capsule, this gray substance, what is this? You saw it in the axial cut before. It's a basal ganglia, the most lateral basal ganglia, the putamen. So that's the putamen. And you see that above the putamen, we have the junction of the external and internal capsules. This is the corona radiata, beginning of the corona radiata. Yes? Good. Next step, we will remove the whole external capsule. We will uncover the putamen and also part of the ventral stream. So we had the dorsal stream, which was removed. We have the whole corona radiata. This is our corona radiata. And what's the name of this long fascicle connecting frontal and IFOF, or inferior front occipital? Perfect. So this is the most superficial part of the ventral stream, because it's ventral to the central core. Okay, so let's go for that in the dissection. And again, Vernon and colleagues, feel free to interrupt me if need something. We keep going? Yeah, you want a cup of coffee or something? I have it here. Thank you. Okay. So this was our extreme capsule. Let's go for the next step, which is the external capsule and the claustrum. Don't forget that we will have the claustrum here. I will need the non-teeth forceps, yeah. For this dissection, this part I like to use the forceps because you can hold your extreme capsule and take it out. Can I have some? This is water? No. Okay, it's fine. So going for the external capsule, now it's appearing here nicely. I'm gonna do something artificial to show you the anatomy. So I'm cutting the most anterior projection of SLF. So you can see how the external capsule is running below the SLF. Can you see it there? Yeah? You see? Okay, so that's our external capsule. We know now. So we know the depth, and we are careful. I don't know if you can perceive it, but this area here is a bit darker. The claustrum starts appearing right there. And you will not see something very well defined. It's very, very thin layer of gray matter. So generally this is the limit in most of the gliomas. The external capsule is the medial limit. So they don't grow generally to the basal ganglia. I have seen some cases in which they do that, and especially these are reoperations or radiated tumors in which we break that barrier. Basal ganglia gliomas are very, very rare. So this is the external capsule, and always correlate this with your coronal cut. Remember, these are called capsules because they are encapsulating the putamen. And now in this part here, I'm gonna remove the external capsule and show you something dark, which is the lateral aspect of the putamen. I don't know if you can see in the screen, it's darker, this area. Not yet. Some more fibers. And now I enter the putamen. Yes, you can see it's quite dark. Huh? Lateral aspect of our putamen. Okay, so let's keep that intact, part of the external capsule, because next we will go to the ventral stream. Mainly IFOF, as you described before. So the IFOF is the first long association fiber system and will be in that relative location. So what we do to uncover the IFOF is we start working with the gray matter of the Lymen insula. It's a bit more difficult to remove. You see, it's more attached. And here, in this area of the Lymen insula, we have not only the IFOF, but another hook-shaped fascicle. Do you know the name of it? Uncinate. There is someone there that knows everything, and I want to meet her, because she's helping me so much. Okay, so let's start working in this area where the IFOF and uncinate are together. So remember, the uncinate is joining fronto-orbitary gyri with the temporomesial structures, so mainly the amygdala and the temporal pole. So removing the cortex, and now some white matter starts appearing. Okay, let's remove the cortex. And here, this is a structure that we don't usually see in surgery because it's quite deep, but if you split the proximal aspect of the Sylvian fissure, this is the inferior peninsular, and this is the Lymen, and this is the planum polare. So if we enter here, we will reach the amygdala. The amygdala is right there, at the uncus. Remember the uncus? Right there. So this is our amygdala. So you can see how you can reach the amygdala from a trans-Sylvian exposure. But before reaching the amygdala, we will uncover the uncinate and IFOF. So I'm removing the gray matter. I'm removing part of the claustrum now. And the ventral stream starts appearing there. You see those fibers. So these are the uncinate fibers, the ones going to the temporal pole, and then we have the IFOF, which runs posteriorly. Okay. I don't know how to hold it, so do you make it? No worries. You tell me if it's nicely exposed. Okay. So taking more gray matter in the Lymen to clearly see what's uncinate and what's IFOF, because they are really together here. Yeah, that one. And this uncinate, we call it a paleopallial association fiber system because it's connecting really paleopallial structures, fronto-orbitary, gyri, and the amygdala. So now get ready because you are going to see the IFOF nicely. Thank you, Vernon. So let me clean it a little bit more. But again, in the Limen Insula area, we have both the IFOF, which is a bit more dorsal, and the uncinate, which is a bit more ventral. They follow the same direction here, but as they go superiorly and inferiorly, the IFOF runs posterior, and the uncinate runs to the temporomesial region. So let me try to show this to you. Sorry. So that's why I go to the main core of both. And then once I have a tract, I just follow it. And it will tell you that this is IFOF, you see? And this is uncinate. So again, we go to the main trunk, we take some fibers, and we follow them. They break because they are running below this extension of the arcuate. So we need to take the arcuate partially now. As we want to follow the IFOF, we need to go deeper to the next layer. So for that, we need to go below the arcuate. But I want to preserve part of it so we can see later on all these structures. You see, just below the arcuate, we are having those association fibers. So this is the point where ventral and dorsal streams join together. Again, our hot spot. So following the IFOF posteriorly. Let me go again to the main trunk. And this is what I wanted. Forceps, yeah, non-teeth. Yeah, no. Not the other one, sorry. This one, yeah. So IFOF going to the occipital lobe. This is the one. And uncinate going to the temporal lobe. So you see now IFOF and uncinate, yes? Just follow the fibers, take your time. Still some, oh, sorry, thank you. Still some fibers of the arcuate remaining that I'm taking out. So we follow the IFOF to the occipital lobe. Can you zoom out a little bit? That will be more understandable, I guess. Okay. So follow them posteriorly. Spatula, yeah, the big one. So our arcuate, which was cut here, and below the arcuate we have the IFOF projections. inferior fronto-occipital, long association fiber system, the most important one on the ventral stream. Okay, so I'm gonna try to just to follow the IFOF till the end. So I'm removing cortex and projection fibers here, so as to show you how it really reaches the occipital lobe. U fibers out. You see how it's curving, because deep in here we have the atrium and the occipital horn. We'll show you in a while. This is the longest association fiber system in the human brain. You see, it's crossing the whole. You see? Can you unzoom as much as possible, please? Okay, let's follow it to the anterior frontal pole. Yeah, that's perfect. Okay, so we see a nice IFOF from the frontal to the occipital lobe, uncinate joining fronto-orbitary and temporomedial. We have our SLF3, our arcuate, which I cut here. We have the external capsule, putamen external capsule. And I think before going deeper, can it be visualized? Is it clear for you? Yeah? Thank you. So let me work a little bit more on the uncinate, which I think it's still not very clear. This is a hook-shaped tract, but very important to understand because it's connecting the amygdala, which I'm already uncovering here. So this gray matter I'm taking is the amygdala. Right there, that's the amygdala. So you see now the uncinate nicely, huh? Yeah? This hook. Okay, so we could go to a practical scenario. So we rest a little bit. Can we go to the presentation? I think, to be honest with you, I don't remember what I have here. Okay, let's skip this one. This is mainly a motor strip tumor. Well, let's have a look at it, maybe. So this is the corticospinal tract. These are the somatosensory projections. So the tumor is pushing them anteriorly and posteriorly. It's mainly growing in the pre and post-central gyrus. So it's in this corona radiata thickness. So it's right there pushing the fibers anteriorly and posteriorly. So it's a tumor which is mainly growing right there, pushing and opening those fibers, as we can see in the tractography. And this is the 3D reconstruction. We implement the venography in our 3D, and then we translate this to our surgical view. So we have a good orientation, and we know that tumor is in the post and pre-central area. So this is less eloquent in terms of motor function, obviously. So we decided to go from posterior to anterior, trying to identify where the corticospinal tract is. And once we reach the most anterior part where we have response, we stop the resection. So this was our ventral stream. This is the picture we are trying to get. I removed the arcuate and SLF, but if you allow me, I will keep this in the dissection till the end. So corona radiata, the external capsule has been removed. So this is the limit, superior limit of the internal capsule. And these are the projections of the corona radiata. And this is our IFOF. Dorsal stream, ventral stream. So this is the next step in which we are right now, IFOF and the uncinate, and putamen just above it. Okay, we did that. And I want to show you this example because we saw a purely insular tumor. And this one is different. This one is an operculo-insular glioma, which is invading the fronto-orbitary, as you can see there, the temporomesial, so it's invading the amygdala, and also the anterior lobe of the insula. So it's a different tumor. It's an operculo-insular glioma. It was on oligodendroglioma grade 3. And you can see the area in which we are working right now. What is this tract? You don't see a tract, but you know that there is a tract there. Uncinate. So this tumor is mainly using that uncinate to invade the fronto-orbitary and temporomesial region. It's mainly located in the lumen of the insula, yes? You see the posterior insular and anterior insular lobes pushed posteriorly. So this will be our next step. We will remove the IFOF and uncinate, and we will see this loop. Do you know the name of this loop? Meyer's loop. Yes, perfect. So this is the next layer we will have. And Meyer's loop is covering the temporal horn of the ventricle. And inside the temporal horn, we have this. What is this? Hippocampus, head of hippocampus. And just extraventricular and anterior to it, below the lumen insula, we have an almond-shaped structure, which is the amygdala. Great. So look at the FLAIR image. You can see nicely, much better than in the T1, how the tumor is not only the insula, but also in the fronto-orbitary and temporomesial regions. So we need, in this case, a transopercular approach, because the tumor itself, it's in the operculi. So we will use this fronto-orbitary and temporal windows. This is the relevant anatomy. These are the MCA branches, and I showed you a lenticular striate before. If we remove the putamen, we will start uncovering these lenticular striate arteries, which are very relevant because they don't only feed the basal ganglia, but also the internal capsule. This is the internal capsule. And let me show you how this case went. So this is right side. This is Sylvian fissure. I take some CSF out. We are localizing the motor strip and just placing an electrode. And this is right side. We didn't do it under mapping, just checking the motor function. And we are working now in the T1, anterior part of T1, so transopercular approach. Now, after removing T1, this is the insula, we are approaching the amygdala. And once we remove the amygdala through the lumen insula, we access the midbrain, lateral aspect of the mesencephalon, which means that we are ready there. Now we want to go to the frontal operculum. So this is the fronto-orbitary. Again, we are removing. This is the MCA in the lumen insula. And we have some lenticular striates there. Once we see them, we don't touch them. We just cover them. But they are so fragile that even some vasospasm could cause a problem. Now we are moving backwards again to the temporal window. We are removing the uncus. That was the uncus, removed from the lateral aspect. And now what we want to do is to join the resection through both transopercular windows and remove the insular component. And we can do that. And this is the post-op, very nice, but you see this hole here? That's a very small infarct on the internal capsule, because one of those lenticular striates probably got a spasm and caused this. Not very relevant. He had some, let's say, praxic movements. He could move perfectly, but he had some movement problems. Even a very small lenticular striate could cause a tremendous problem. So that was the removal. And this is the next step. I told you that once we remove the uncinate and IFOF, we will uncover the optic radiations. And here I have also removed the putamen. So here in this ventral stream, we have three important fascicles: IFOF, optic radiations, and also part of the commissural fibers belonging to the anterior commissure. That's very difficult to understand if you know the anatomy of the anterior commissure, but the anterior commissure, I will try to show you that it's also connecting not only temporomesial regions, but also connecting the posterior part of the temporal lobe and the occipital lobe. So it's running posteriorly. And these three fascicles are like, again, like onion layers. So we have IFOF, anterior commissure, and optic radiations. And they are called sagittal stratum. And they are called sagittal stratum because they are organized like the stratum of the Earth, like this, in a sagittal direction. So that's why it's called sagittal stratum. So, say again? Yeah, let me show you. It's not here, but it's right here. I have removed the IFOF, and this is the anterior commissure. You see? Yes, ventral to the basal ganglia. So after removing the IFOF and removing the basal ganglia, partially I didn't do it here, but I will do today, we see the anterior commissure running not only to the amygdala, which has connections to the amygdala, but also posteriorly. If I cut the anterior commissure and peel it away, I uncover the last layer of the sagittal stratum, which is the optic radiations, Meyer's loop and optic radiations. Yeah, you see how it's covering the lateral aspect of the temporal horn. So what is this? Amygdala. What is this? Head of the hippocampus. So you can see the very close relationship of all these structures. So through the inferior peninsular sulcus quite anteriorly, we can access the amygdala and we can access the head of the hippocampus, trying to preserve the Meyer's loop. This is the so-called selective amygdalohypocampectomy. We try to preserve these optic radiations. So let's try to dissect the sagittal stratum. I don't know if you need a break, Vernon, or... Oh, question, yes. Yes.
Remove the tumor. I personally am against the CUSA for a couple of reasons. More so in low-grade gliomas, because you see the tumor, you also feel the tumor. So when I use my biopsy forceps, it's like my pen or it's like a cricket bat that I use when I play cricket. So you get a feel of the tumor. And you even know, oh, this is tumor and this is not tumor, even if you have your eyes shut. So I'd like your comments.
Thank you. I truly believe what you kindly mentioned, and I do that also. But when we are dealing with quite large tumors, I try to understand the limits in the lateral surface, and I do the bulking with the CUSA. And sometimes when I'm reaching the boundary, that's why I use the subcortical stimulation on the CUSA. Then I shift to a very, very low intensity of the CUSA, or very low intensity, 20. 10 is not working. I tried it, but it's not working. So I use 20, and then I try to find that feeling you are talking about. Yeah. But I fully understand your comment. I really appreciate it.
And you know, the funny thing is that if you just compress fibers, they will work. But if you use the CUSA and you lose the vessel, that's gone. You'll get many more dots like you showed us.
You're right.
So the CUSA, you don't have a feedback. There's no feedback from a CUSA. Whereas all micro instruments, you get a feedback, even if it's a microbiopsy forcep or if it's just a simple forcep. So this is my concern.
That's a perfect comment. I really appreciate it. I never thought about that, but somehow I do something like what you do, but instead of perceiving that feeling that I think it requires experience to have that feeling, what I'm doing for the time being is I'm using this subcortical stimulation, so I have the feeling about how close I'm getting to the fibers. But yes, about vessels, you don't have that control. If you damage a vessel, you cannot predict damaging a vessel with a CUSA. So.
One more comment about the fact that when you use a stimulation, you always know that current can jump. You don't. How do you know how close you are? You may get something that shows that you're close to something, but how do you understand how close you are? Because for me, these are props, the CUSA, the stimulation. So I'm trying to remove all these props from my life and try and do what I can do best. And then I'm only solely responsible. I can't say, oh, the stimulation was there, and I've left that, and then I have so much tumor behind. Or the other way around, you know, I've gone across the limits, and I cause a deficit, and the patient has hemiparesis. So again, your comments on here, the electrical backup that you have.
Yeah. So the first thing we do before even connecting the suction, and obviously we place the CUSA on a standby, Once I do my regular cortical mapping to measure the threshold of the motor area, once I have it, I go to the same point with the tip of the CUSA, and our neurophysiologist marks the threshold. So this is how we do that. And obviously, with each case, we learn, because we do tractography, post-op tractography, and measure the distance, and we keep the points where we had response at 3, 5 milliamps, and measure the distance. So we are doing research on that. And for the time being, it's between 3, 4, 5 milliamps where we decide to stop.
Amazing. Thank you.
Thank you.
Actually, Adil, when we use the CUSA, we can also bring down the impedance completely, and you only use the suction. So especially when you're doing intramedullary tumors, that's what we do. We normally use only the suction, which is a low suction also. You can decrease the intensity of the suction and go even up to a 0 impedance of frequency. That's it.
Thank you very much. Thank you. So you're ready to keep going? No break needed? Okay. Okay, so let's go for the next step, and let's try to make it a bit faster. So I'm gonna uncover completely the lateral aspect of the putamen, so removing the whole external capsule. We will try to see some lenticular striate arteries in here. So at this point, it's difficult to take them out because they are below the SLF. So in order to have a nice picture, I will cut this capsulotomy, what I'm doing. I'm just disconnecting the external capsule. This is an artificial cut, just to show you a nicer picture. So you see how these fibers are projecting. Again, I need to cut here. These cuts, you don't need to do them during your dissection. This is just for a nice demonstration. And you can see how the putamen appears there. And the point where I'm working now, this is the junction of the internal and external capsules. You will see later on where the corona radiata starts. So again, we follow the anatomy, partially removing the IFOF there and following the fibers. Yeah. So now I will remove the putamen and will access the globus pallidus. The putamen is purely gray matter, which is quite spongy. So it's like removing the cortex from the gyri, and you will be watching that it's very, very easy to remove. But the globus pallidus, it's a bit whiter. Pallidus means something like white, and quite stronger. So I'm starting to remove putamen. Some lenticular striate vessels, you see it? Can you zoom in a little bit? I want to show this vessel, because this is the one I damaged during my insular tumor. You see this? Okay, that's enough, thank you. So I took it out from here, but it was coming from the base, from the anterior perforated substance, which is right there, yeah? Okay. So let's continue with the removal of the putamen, and you might see some of these lenticular striates. One more I just removed. 8 to 12, generally. This is what I read, never counted them. So removing the putamen. Very easy, very spongy. But as I'm going deep, the substance becomes a bit whiter and not so spongy. So lateral aspect of the globus pallidus will start appearing. Now you will see much better the IFOF anatomy. You see it's whiter now and not so spongy. That's the lateral or external globus pallidus. And some fibers inside. Can you see some fibers inside? These are branches of the corona radiata. These are fronto or corticostriatal. You know, we have some projections to the basal ganglia. These are the ones coming from the frontal lobe to the striatum. Corticostriatal in the anterior limb of the internal capsule. Optic radiations I will try to show you, and also anterior commissure. It's sometimes a bit challenging, but everything is running smoothly, so I truly believe that we will be able to see them today. Okay. Now above the IFOF, we need to do that. I need to remove the IFOF, the dorsal IFOF, so as to access that area. Okay. Something that will predict how nice the anterior commissure will be dissected. You go to the midline, and you see what kind of anterior commissure we have, which is this one. It's very small. Sometimes it's much thicker, and in those cases it's easier to dissect. I don't want to cover myself, but let's see how we can manage. So I'm reaching what we call the ventral striatum. A striatum is the junction of which nuclei? Medical students, second year. A striatum, what it is? Perfect. Caudate and putamen. Perfect. So the striatum has a ventral component, which is in the ventral aspect. And this is what I'm just removing now. You see those perforations? Yeah? Some vessels were crossing. Lenticular striate arteries were crossing that. And the anterior commissure should start appearing somewhere near here. So now you should really understand the concept of capsule. I open those capsules, and I'm in between the internal and the external capsule on the basal ganglia. And this, I think, is the anterior commissure, very thin. You see? Yeah? Oh. Yes, because otherwise I cannot even see it. It's here. Let me show you. I don't want to destroy it, I just want to show you these fibers. Yeah? So let's try to isolate it. Can you unzoom a little bit now? I will show you once it's ready. So now I'm removing the putamen, finally, and uncovering the anterior limb of the internal capsule. That is the anterior limb, right here. That's the anterior limb of the internal capsule. You see it? Quite running prefrontally. This is our anterior limb. So now I will uncover the genu. This is still anterior limb. We know that because it's direction. Let me again do a cut of the SLF. We need that. Now we can be a bit more aggressive because we know the plane. So you see, corticospinal tract. Okay. Yeah. And the corona radiata. This is the beginning of the corona radiata. You see what happened there? It crossed. So it's broken. Why? Association, projection, and commissural fibers going to the corpus callosum. So this is the hotspot of these three components: commissural, association, and projection. So as we know our corticospinal tract, we can really uncover now the genu of the internal capsule. So this is the lateral aspect of the internal capsule. And the posterior limb, which is just running below the arcuate. We will leave this arcuate for the end. Okay, so let's try to work a bit more. Sorry. On the anterior commissure side. And so as to see it nicely, I'm sorry, but I need to cut partially the IFOF and push it backwards. So IFOF, and uncinate, and you will see what is IFOF and what is uncinate. IFOF, very thin, and uncinate, quite thicker. So this anterior commissure is really, really thin, which is right there. I don't know if you can magnify a little bit, zoom in. Okay. Okay, that's good. Removing the globus pallidus on the other side of the commissure so you can see it. It's very, very thin, as we saw from the medial aspect. And this is a commissure which is mainly joining also paleopallial. This is the only commissure that some fishes have, anterior commissure. They don't have corpus callosum. Okay, so you see it right there? Yeah? Are you awake? Okay, so this is the anterior commissure. Maybe you don't believe that, but I'm gonna prove you that it is. Can you zoom out? Yeah, you see? And this is our anterior commissure. Do you have something very sharp? That's fine, yeah. Okay. You see? You believe me? Thank you. Okay, thank you. That was a test of awake surgery. Okay, so you can zoom in again, sorry. Okay, so we know this is the anterior commissure. Again, very thin. When it's bigger, it's easier, this part of the dissection. And this is the second component of our sagittal stratum. And identifying the Meyer's loop is probably the most difficult one, especially if you don't see the anterior commissure. But as we have it already, I'm going to cut it, commissurotomy. And let's try removing it. Okay. Now you will start perceiving, instead of longitudinal fibers, pay attention because you will see a curve. We already see something. Yeah? This is still the bed of the anterior commissure. Have you ever heard about the Gratiolet canal? It's a kind of canal in which the anterior commissure is located. So this is the Gratiolet canal, posterior wall. So kindly removing it, we will really uncover the Meyer's loop. Hope so. Haven't seen it yet? Not very clear yet, I know, but I can feel them already. Well, I don't know if you can start perceiving that there is a curve there, yeah? Maybe I'm too optimistic. Do you know that the optic radiations are part of the internal capsule? Did you know that? Of the so-called sublenticular part. Not the genuine, not the anterior, not the posterior limbs, sublenticular part. Projection fiber system from the thalamus to the cortex, to the calcarine. Great. So now removing last part of the anterior commissure. I can touch the ependym of the temporal horn there. So we are very close to it. So could you zoom out to see if we can see it better? Bit more? Okay. Yeah. So this is our Meyer's loop. I still have to uncover a bit more. And now I'm working at the ependymal layer. So let me open the ependyma. So you can see what's inside. Again, every cut you make, you must know what you are cutting. And I'm cutting the projection of the Meyer's loop. So you see, that's the head of our hippocampus inside. Yeah? Let me clean it. You remember the collateral eminence we were talking about? So it's right there. That's our collateral eminence. And now again, I'm going to do something artificial, which is cutting just the floor. These are our optic gradations, our Meyer loop. I want to uncover it. So you can see how, understanding this anatomy, we can go subtemporal through the collateral sulcus, respecting these optic gradations, and we can reach the temporal horn from below. Can you unzoom? Yeah. So this is the very thin layer of optic gradations, and here is our hippocampus. I just want to show you, yeah? So thin, huh? And we see the choroid plexus. You can see the choroid plexus. Oh. Thank you. And this is our collateral eminence. So if we identify the collateral sulcus, which we know it's right here, yeah, we will reach, our collateral eminence. Yes? Good. So this is a safe entry zone. We can respect these optic radiations through this, or we can enter through the amygdala, which is right here. I will show you now. The amygdala is extraventricular, and we can access from this to the head of the hippocampus, trying to preserve as much as we can these fibers. Yeah. Okay, so I think I have a. Do we have time? Yeah. Say again? 30 minutes. Okay. Can we go to the presentation to see if I have something to show related to this? Okay. So I was lucky we got it. Ah, yes, I have something to show you. This is a 56-year-old lady with scissors. So where is this tumor located? Now you know. Look at the axial. Which lobe is this? Temporal. Perfect. And we have, sorry, I need to stand up a little bit. And we had 4 surfaces. You remember? Lateral, basal, mesial, and superior. So it's in the mesial surface. And from the axial view, you remember we had the ancus? Yes? So the ancus was composed of the anterior part, which is the anterior part of the ancus, extraventricular, amygdala, yeah, just below the limb insula, yes? and the head of the hippocampus, which is intraventricular. So this is an amygdala tumor. Good. So, say again? Yes, that's a perfect point. That's a perfect point. I didn't think it was going, but it was. It was, indeed. Yeah. So it's amygdala and head of hippocampus. Thank you. Yeah. And that's very important, indeed. So from the basal perspective, this is the picture we have. Remember the ancus, the pyramid, the apex of the ancus, anteriorly, mainly, this arbitrary amygdala, and posteriorly, head of the hippocampus. So we can trace that line there. Same thing here. After the dissection, this is a basal view. This is the putamen internal capsule, what we have dissecting. I have preserved the optic gradations as in our dissection. I'm watching from behind, from below. Head of hippocampus with the dens of the dentate gyrus, and extraventricular, we have the amygdala. So this tumor indeed was amygdala and head of hippocampus with scissors. So remember the anterior commissure, very important. Because when we are dealing with a tumor which is in the amygdala, the hippocampus, we have clear limits. It's intraventricular. We have our choroidal fissure, we have the superior surface, inferior surface, so we can have some limits. But the problem with the amygdala is that when we reach the most superior and medial part of the amygdala, right there, we don't have a clear landmark. We don't have it. We don't have it. And if we go too deep, we will find our lenticulostriate arteries. So that's a problem with the amygdala. This is a benign tumor, DNET, epilepsy. So our goal was just to release the scissors, because we were controlling the tumor for 3 years, nothing happened, no growing, but he was having scissors. So this is the most difficult part, and is limited superiorly by this anterior commissure. We know that. We cut it. You remember? We just cut it, so the amygdala was below. So these are the dissections, and this is something similar to what we have now on the table. Optic gradations, head of hippocampus, amygdala. So in this case, we can do this Transylvian approach, which sometimes is a bit dangerous because we have the main vessels there, but we have a good thing, which is the so-called transplanum polare approach. You know where the planum polare is? So we can go quite anterior through T1 in the subpial component, and I will show you, and you are outside the arachnoid. Indeed, you are inside the arachnoid. So you are aware and away of the vessels. So you reduce the chances of damaging them. And I'm using that a lot instead of the Transylvian. I will show you how. So this is... That's perfect. Indeed, the amygdala is not the stem, but it's covered with the stem. What is a stem? You remember what I have done here? Sorry. I have cut the fibers. All these fibers are connecting the temporal lobe with the central core and with the frontal lobe. So it's a kind of a stem. If you cut those fibers, you are disconnecting the stem. That is what we call a stem. Optic gradations, anterior commissure, IFOF partially, uncinate mainly. So these are fibers in the Limen insula. All this packing of fibers are the so-called stem of the temporal lobe. Yeah. But so we want to go away of the stem. So that's why we go so anterior. We want to avoid damaging that. We don't do this, what I did in the dissection. We go anterior. So that's why we need to go as anterior, as polare as possible. I don't know if I answered.
Yes, but you said that you avoid the stem.
I try to.
Then how do you enter the ventricle without...
through the amygdala.
Through the amygdala.
Through the amygdala, yeah. So you go quite anterior. You can do purely Transylvian and enter the amygdala and then the ventricle, or you can directly go transplanum polare, like this. Planum polare quite anterior, so the stem is here, not there. And then you enter the amygdala, and finally the hippocampus. And with that, you are trying to preserve the stem, because you go quite polar. Great. Some people are doing that now, transorbital. I saw some reports about that. I think it's too much. But you see my point?
Yes,
if you go quite polare, you avoid the temporal stem. So this is left side perineal craniotomy. The dura, this is the frontal lobe, the temporal lobe. And very important, electrocorticography, because sometimes this is not a tumorectomy. You don't want to take the tumor. You want to cure epilepsy if possible. So sometimes this tumor, despite the fact that they are in the temporomedial aspect, sometimes we have activity in the neocortex. So we need to know that. We can do deep electrodes, or we can place agreed, which is what I usually do. So we are releasing CSF. This is the first maneuver. Then we do our mapping, MEPs. We continuously check that. We are not near the corticospinal tract, but maybe some vessels, yes. And this is our electrocorticography. We put it as far as we can. And in number 17, at the level of the fusiform, more or less, we had the epileptic activity. So we don't want to finalize surgery till we have released that seizure. So this is the most anterior part of the sylvian fissure. I always have a look in case it's a nice anatomy and it's safe. We go through. I didn't think it was safe to go through the lumen here. So I went back and quite anterior in T1, very anterior. I do a small corticotomy, and then I have my landmarks. So I know how close I'm to the vessels, but I'm inside the arachnoid. So this is the amygdala already. Through a small corticotomy in the planum polare, you reach the amygdala, and subpially, we are removing the uncus. So this is the P2, posterior cerebral artery, and the third cranial nerve will appear there. You see where we are in the anterior part of the uncus. Quite anteriorly, this is P2, running posteriorly, and then through the amygdala, the stem is here. Through the amygdala, we go inside the ventricle. This is the nice subpial resection of the uncus. You can do that because it's not severely attached to the arachnoid. So this is the midbrain, the lateral aspect. This is the optic tract. And then we enter the ventricle, and we see the head of the hippocampus. And that was the superior part. And at that point, luckily, once we removed the hippocampus, the spikes disappeared. So that was VERNON, that the tumor was in the hippocampus also. And it was at that point when we took the head of the hippocampus out. So most of the times it's not so easy, and you need to expand your resection even to the fusiform or to the neocortex. But in this case, we were very lucky. The patient was very lucky. And this is the post-op where we can see the stem, indeed. This is the stem. Yeah? So we go anterior and below the stem. You can see the stem here. We didn't cross it. We went anteriorly to it. Yes, does it make sense? Okay, so this is what we have seen already. And I don't know how is the time, Vernon, and how energy is still in you.
You can ask them.
How are you? Should we continue a little bit more? Yeah? Okay, great. So, optic radiations, and this is a different...
One more landmark, like you were showing the hippocampus on the surgical video, or maybe on this as well, the choroid point.
Inferior choroidal point.
Yes, inferior choroidal point.
So, let me think if I have it. Well, I can show you here. I can show you here. The inferior choroidal point is just behind the head of the hippocampus, and it's the point where we have the choroid plexus attachment and the anterior choroidal artery entering the ventricle. We will show it here. So this is the atrium opening. So now all the anatomy that we have been removing makes more sense. Internal capsule with the last part of the internal capsule, which is the optic radiation sublenticular component. I remove the ependyma, so we can see the atrium and the choroid plexus and the frontal horn and body of the lateral ventricle. So the capsule has been cut here. This is a capsulotomy, complete capsulotomy, and this is the cingulum in the midline. Next step, cutting the optic radiation. So again, we can see the amygdala, head of hippocampus, anterior commissure, the IFOF and optic radiations have been cut. So this is the direction following that, sparing the temporal stem, which is ventral stream. Amygdala, head of hippocampus. This is the tail of the caudate. This is the tail of the caudate nucleus, which reaches the amygdala, you see, in the roof of the temporal horn. And from below, we can see the dentate gyrus with the head of hippocampus and the amygdala again. And if we continue, this is a different specimen where we can see that, I did a capsulotomy, so it's showing how we can see the ventricles. And you remember I was asking you, telling you about the anterior and posterior insular points, access to the frontal horn and atrium. But we need to cross the internal capsule to reach that. Important fibers of the internal capsule are the motor fibers, which are right here. So we could try to go quite posterior or quite anterior to it if we want to reach the ventricle. But generally, we use different approaches for the intraventricular tumors. We go through the midline or through a different perspective. And this is a case that really illustrates the anatomy we've been watching from the lateral aspect. So it was operated in 2012. It was pathology. Grade 2, if I remember well. Grade 2. Pleomorphic xanthoastrocytoma, grade 2. It was only here. So in which lobe is this tumor? Which is this lobe? Insula, the posterior insular lobe. Now we know that, yeah? Posterior insular lobe. And this was the recurrence. Where is it? Is it medial or lateral to the internal capsule? Medial. Huh? What is medial to the internal capsule? We didn't mention this structure yet. Thalamus. So it was a crazy tumor. It was, again, recurred here and appear in the thalamus. So we were discussing if a young patient, neurologically intact, and he had some very, very mild paresis progressive in the last few months.
Initially, where was the tumor?
The tumor was here, in the posterior insular lobe. There was a small remnant attached to the angular artery, so that's why my boss decided to leave it there, and it took 8 years to grow, to be honest with you. So it was well done. But then we had a growing here, quite a large growing in 6 months, and this one which was very ugly. It was not 6 months before. So we were discussing about a single approach, and a single approach means that we should cross, what is this?
You can see it also on the coronal cut.
Yeah.
You can see it beautifully on the coronal.
Yeah, exactly. This is the posterior limb of the internal capsule. But here we expect to find some somatosensory fibers. We lost the image. Sorry. We lost the slide. So, tractography, to confirm our thinking that you didn't need anything, any tractography. You knew that these fibers were there, and that's very good. So in yellow, we have the corticospinal tract. What is this in red? Arcuate, perfect. And in green, you cannot see it completely, but it's connecting frontal with occipital. IFOF, okay. So we try to go, again, through the same transinsular, quite posteriorly, and to try to cross, to check with the probe if there were motor response, and if not, to go through the capsule, internal capsule, which is something that was not in my plan previously. Let me show you this dissection. This is an axial cut with a superior dissection, so I took the putamen. It's removed the putamen. So you can see now, understand the concept of capsule. External capsule, internal capsule, and in between them, the basal ganglia. And what is this? It's a commissure. It's the anterior commissure. It's a crazy understanding of it, but if you have this 3D image again, you can understand that this is the anterior commissure, a thick one, much thicker than ours. So, that doesn't mind too much. And this is the thalamus. So, internal capsule, posterior insular, thalamus. So we wanted to cross the internal capsule at this point, and motor fibers are expected to be near the foramen of Monroe. So we were quite happy with that. So this is internal capsule, and this is what we did. We reopened the wound. So this is the ear, left side. So this is a linear incision, quite posterior temporal craniotomy. And we want to identify the sylvian fissure, posterior sylvian fissure, and to open it, quite posterior. It was dominant hemisphere to make it more challenging. I'm using a lot now the ultrasound. So I'm using some cotonoids. So I was removing now the component on the insular surface of this pleomorphic xanthoastrocytoma, and I saw what my boss did. It was very attached to the angular artery, so that's why he didn't go deeper. And now, we stimulated here this internal capsule, no motor response. So we checked with the ultrasound with this cotonoid how close we were to the tumor. We were just inside the tumor. So we opened the capsule. This is the capsule. You see it's wide, very, very nice. And this is the tumor already. So 2 millimeters of capsulotomy, very small, very small. So as I was moving anteriorly, I needed more space. Then I had motor response. So couldn't continue. Didn't have space enough for that. So couldn't remove that component completely. I was not feeling comfortable. So at this point, I stopped right there. I had motor response there because it was so close to the corticospinal tract. And things are not like this in surgery, because you release CSF, you take some tissue, so things change. So you cannot predict that this is a picture like this. So that's why I really trust subcortical stimulation in this point. And this is the post-op, as you were expecting. This is a small hole we did in the internal capsule, and we couldn't remove the tumor completely in the thalamus. So 2 weeks back, we decided to do a midline approach, interhemispheric, transcallosal approach. So same site, now we are approaching the midline. So this is the interhemispheric fissure, and I'm using these cotonoids to open the space. We were discussing, Vernon, yesterday, the use of retractors. This is my retraction. And these are both cingulum. I'm using the navigation to make sure how close we are to the corpus callosum, and then we do a small callosotomy, and the same story starts. We go from posterior to anterior, trying to see how close we are getting to the internal capsule. This was the pre-op, and this is the post-op, in which some remnant could be there, and this was grade 3. But you see how the corticospinal tract now it's much nicely visible. So we use radiation chemotherapy, and he's, for the time being, 3 years after this surgery, we have some remnants, but it's not growing, and he's nicely recovering.
This
So
is above the choroidal fissure.
say again?
This is above the choroidal fissure? Or you have to go through
This is above the choroidal fissure, yes. I entered through the cingulum and the corpus callosum. So I directly face the thalamic tumor. Yeah.
It looks like a multifocal. It doesn't look like a continuation.
Yeah, I couldn't find any continuation. That's why I'm showing you this case, because it's something that I never found.
This also.
Yeah, it must be a genetic disease behind. We are trying to study, but we didn't find anything, to be honest. But yes, there was no continuation. The barrier, and the fact that I wanted to show you this case is that this is our anatomical barrier. The internal capsule, the corona radiata indeed, is separating the lateral from the medial aspect. And we just showed right now the lateral aspect of the corona radiata. So behind that, we have the medial aspect and the limbic structures.
excellent demonstration.
Yes. You mean in the first surgery? The problem is that it was the dominant hemisphere, and the superior parietal lobe. Yes, that's something we could do. Yeah, that's something we could have done. But to be honest with you, after this first stage, I was quite done. Yeah.
Excellent, Pablo. Are you going back to the...
Yes, we should see the intraventricular anatomy. You still awake? Oh. Yeah.
Maybe just the temporal horn and...
4? Say again? Chandra? Say again?
Just the temporal horn. I wanted to see the choroid point, but
Okay.
I think we don't have more than 5 minutes now.
Okay. So if you allow me, I will remove the optic radiation so we can have a view of the temporal horn. Yeah?
We can ask our young friends if they want to see anything else.
Okay. So next year I come for the medial aspect. Eh? Okay. Oh, thank you. Okay. Can you unzoom just to see our whole corona radiata? So projection of the internal capsule. It's covering the medial aspect, you see? And that tumor was behind this point in the thalamus. So what I'm going to do now is I will just open the ventricle. All the way from the occipital to the frontal horns. So what I'm doing right now is what it's called a functional hemispherotomy, which is a procedure used for intractable epilepsy. And what we do with that is disconnecting, completely cutting all the projections of the hemisphere. It's not a curable procedure, but a palliative one for those patients who have a tremendous number of seizures. So let me show you the inner aspect of the temporal horn. This thin layer is the optic radiations. So you can see the hippocampus and the choroid plexus there. Yeah. Okay. So I keep working on my capsulotomy. Sorry. How much, how long time do I have? So 20 minutes more? Okay, okay. Yes, because after this, we can have a discussion, and I have an experiment for the medical students and for the residents. So I'm cutting the internal capsule completely, as we don't have time to do it from the medial aspect. I will take it out. I'm sorry, I know you don't see, but I want to. So instead, Chandra, of showing just the temporal horn, I'm trying to show all the ventricular, lateral ventricular system, from the frontal horn to the body, passing through the atrium, occipital, and temporal horns. Okay. Okay. So our capsule, the internal capsule, the putamen was there. What is this, gray, behind the internal capsule? Head of the caudate, great. And you know, the head of the caudate and the putamen are called striate because some stria of gray matter cross the internal capsule. So there are some bridges of gray matter. That's why it's called striate. Just for a nice picture. So, frontal horn, body of the lateral ventricle, corpus callosum, which is the roof of our ventricle. This is the atrium. This is the occipital horn. The optic radiations were removed. And this is our clomus of the choroid plexus. Can you zoom in? So, and our hippocampus, and the amygdala is right there. So this is our direction, indeed, for the amygdala hypocampectomy. Zoom in a little bit. Okay, that's okay. Okay, so head of the hippocampus, and if we follow the choroid plexus, and take it out, I want to see the inferior choroidal point and the anterior choroidal artery. So that's the inferior choroidal point, right there. Right there. And you see the choroidal artery? Okay, and you see that fissure? Do you know the name? Choroidal fissure. You see the, can you zoom in? The bridges of arachnoid. This is closed in normal conditions, completely closed. And you see that bulging thing? What do you think it is? Say again? I cannot hear you. That's the lateral geniculate nucleus, where the optic tract is finishing and from where the optic radiations are coming. Part of our visual apparatus. Yes? Does it make sense? So this was our inferior choroidal point. And that is the midbrain. Yeah? The midbrain. Okay, can you unzoom now? Sorry. So I'm going to take the whole choroid plexus out. So you see that the choroidal fissure from the temporal horn is giving us access to the ambient cistern. But here it's giving us access to the quadrigeminal cistern. And as we move superiorly, if we cross this choroidal fissure at this point, which area will we reach? Thank you. Let me show you from here, you understand much better. Here, the third ventricle. This is probably the most complex concept, choroidal fissure. Because here, it gives us access to the third ventricle. Here, it gives us access to the quadrigeminal cistern. And here, it gives us access to the ambient cistern. But you can see it now. Yes? Good. So let's take it out completely, the choroid plexus, so we can uncover the choroidal fissure. So I can show you. This is my first experience with the exoscope, so I'm sorry. But it's beautiful. Okay, so hippocampus, fimbria, crus fornicis, and body of fornix with the anterior column. You see? Following the same direction than the choroidal fissure. Yes? Access to the ambient cistern, access to the quadrigeminal cistern with the colliculi, which are right there, colliculi, and access to the third ventricle. Mammillary bodies, we need to have a look from basal. Mammillary bodies where the anterior column of fornix, which is here, is, do you want to see the mammillothalamic tract? Thank you, me too. So this is the anterior column of the fornix. This is hypothalamus. This is the thalamus. So if you join a line, if you trace a line between the foramen of Monro and the aqueduct, you have the so-called sulcus limitans, or hypothalamic sulcus. So anteriorly hypothalamus, posteriorly thalamus. Can you zoom in a little bit? So now I'm removing the medial hypothalamic nuclei. Bit more, please. Okay. So the anterior column of fornix is traveling in the thickness of the hypothalamus. And just behind our anterior commissure, which is right there, you see it? Very thin one. These are our fibers of the anterior column of fornix, which this needs to be done with the exoscope, and I'm watching it directly. So this is gray matter, and this is white matter. And the mammillothalamic, you see the fornix, eh? Yeah? And now let's go to the mammillothalamic tract of big Dasir. This is the so-called circuit of Papez, or Papez circuit, yeah. I'm damaging it a little bit, you see it? These fibers. Okay, so let's keep going. And this mammillothalamic tract is the end of the Papez circuit, and it's joining the mammillary body with the anterior nucleus of the thalamus. And now I am uncovering, you won't believe that, but the superior aspect of the subthalamic nucleus. Okay, so let me speed up a little bit. This is the thalamus. So just below the thalamus, we have the red nucleus and the subthalamic nucleus, just medial to the mammillothalamic tract, which I have broken a little bit. Well, at least we can see the anterior column of the fornix going to the mammillary body here, and the mammillothalamic tract. I have already destroyed it partially, but are these fibers which are running upwards there, right there. And this is the red nucleus in the floor of the third ventricle. Just here, it's not red. And just lateral to it, we have the subthalamic nucleus, which is this gray substance, the tip of my wooden spatula. Yeah? Sorry to have finished with such an ugly picture. Can I have more? Thank you. Okay. So anterior column of fornix, mammillothalamic tract partially ruptured, the red nucleus, which is right here, and here we have the subthalamic nucleus, a bit more lateral. So that's it. Let me maybe anything else from your side, Chandra and the team? You're happy?
No, thanks, Pablo, very happy. You must have a dialogue with the young people before we end the session.
Some interactive session.
You can ask or you can speak to them.
Okay. So can we go to the presentation? I have something to finish because I told you that we had initials. Oh, can I manage here from here? We started with a picture.
Oh yes, the very first one. Flowers
Hmm. And I showed you this. This was the first slide this morning. It was this morning, isn't it? Yes. Not yesterday. So, can I ask someone, can someone help me? It's not an exam, just it's an experiment. Who is helping me? Vernon, who is helping me? One of your guys. I'm sorry. Hello. Thank you for your help. So can I ask you about this case? You were present the whole morning? You were here the whole morning? Not for this one? Much better. So this is a patient who came to the clinic. I showed this case at the beginning of the morning, and he was biopsied, and they thought it was a GVN. He was neurologically intact, no symptoms, just headache, and they found this, and they took a biopsy, and it was grade 2 pleomorphic shantoastrocytoma again. So which lobe would you say? Which lobe? Which side, by the way? Right or left? Left. 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 And which lobe? Parietal. We have a microphone for him? No, no worries. Yeah, great. It's parietal. Very good. So parietal. Yes. How do you know that? Which coronal, axial, or sagittal is giving you the clue about that?
Axial cut.
Axial cut. Perfect. And how many mainly structures we have in the parietal lobe? You remember we showed them?
Superior, inferior.
And inferior is divided in two.
3.
The inferior is divided in two. You know?
The opercular is?
No, the parietal lobe. Inferior parietal lobe has two components.
The supra and inferior.
Supramarginal gyrus?
Inframarginal. Angular.
Angular. Good. Thank you.
Can we have the lights, please?
Okay.
Lights on.
I'm sorry. But you're doing great. So, supramarginal is anterior, and angular is posterior. So where do you think it is, this one?
Angular.
Angular. Do you all agree? Yes. Okay. So we have a left side angular gyrus tumor in a neurologically intact patient. You remember you were here within this hotspot area we were showing? This is that hotspot area where we have a crossing of fibers, yes. Many fibers. So can I ask you, we have 7 fibers there. Can I ask you some of them? Can you tell me which one you are scared about? Let's start from the surface to the depth. So once I remove the cortex, what do I have? U fibers.
U fibers.
Okay. Next layer. I uncover that. SLF vertical. Yeah? SLF. What else?
Arcuate.
Arcuate. So we have 3 already. We have 3. Arcuate is supposed to be a bit anterior. You see it? Yes? We have 3. What else? IFOF. 4. Optic radiations. 5. Uncinate is quite far away. Uncinate is quite far away. So U fibers, SLF, arcuate, optic radiations, internal capsule. Which part of internal capsule?
Posterior.
Sublenticular and posterior,
Posterior.
Yeah? And I don't know how many we have already. Anterior commissure. Anterior commissure also. You remember it was running posteriorly. And finally, there is something that I didn't show you, and I'm sorry, it's the so-called tapetum, which is a very thin layer of fibers coming from the splenium. 7 fibers.
10 fibers.
Thank you so much. Thank you. So we have all the 7 fibers, yes. So these are the fibers we want to be aware of. And these are all the fibers here. You said them perfectly. U fibers, arcuate, SLF. So these are the fibers that you expect to deal with during surgery. And the patient was intact. He was speaking Spanish, English. He was married with a Dutch lady, so Dutch. And he's a biologist speaking with monkeys, communicating with monkeys. We couldn't test that, obviously, neither Dutch. So this is the anatomy we want to be aware of. So IFOF, optic radiations, arcuate. You can go, you can go. And how we design surgery is we want the eloquent fibers. There are different strategies, but generally we like the eloquent fibers to be dealt at the end of surgery, because the patient is awake and we want to keep him quiet till the moment in which we need to approach those fibers. So this is the summary. From the depth to the surface, this is the tapetum, optic radiations, IFOF, arcuate. We didn't see the MLF, we didn't see the ILF, but it's there also, and vertical component of SLF. So all these fibers. So we designed a surgery in which we wanted to test speech for the arcuate and the campimetry for the optic radiations. So this is how we start. We start our mapping to decide where to go in. Then we do our subcortical stimulation, and we start from posterior to anterior. So this is the point where we want to stop, which is right here, when he's having some anomia or speech arrest, in that point here. And finally, once we are reaching, and this was something quite new at that time, it was 5 years back or 6 years back, we did a campimetry, intraoperative campimetry with the bioengineering department. They created this screening which he could touch the deficit or phosphines he was perceiving. So he had to look at the center of the image. He had 4 different videos, and during our triphasic stimulation of the optic radiations, he was not having any problem. But then at this point, quite deep, this is the atrium, this is the hippocampus in the tail, the anatomy I just showed you right now. So we were stimulating upwards to the optic radiations, and he was drawing this shadow. No phosphines. It's a negative stimulation because we are blocking the fibers. We are not having stimulation. It's not stimulation, it's blocking of the stimuli. It's different if we stimulate the neurons, where we have generally phosphines. Different shadows he was perceiving, so this was helping us a lot in order to maximize the resection of a benign tumor, which generally, why is intact this patient? Because these tumors, pleomorphic shantastrocytomas, generally are not diffuse. They just push the fibers quite a lot. So that's why we had this chance to keep this patient intact. And with this, all this knowledge, anatomy, functional thing, we had this post-op MRI, which if I see this post-op MRI without this, I would say this patient has a myopia, but he had not. Why? Because we knew the anatomy, we designed a good surgery, and we had perfect colleagues for the awake surgery. The patient was excellent, and the bioengineers helped us a lot. So it's not a one-guy surgery. This is a big team, a great success. So that was all. Thank you so much. I hope it made sense, and I really appreciate all your time.
Thank you. Thank you, Pablo, for a wonderful session. And I hope you all have gained a lot of knowledge. We are in time. He has a flight to catch at 6 p.m., so he'll be leaving soon. And I'd like to thank all of you all for coming and enjoying the show, because you have to enjoy dissection. It should not be punishment. When you are in the anatomy dissection hall, enjoy it. Enjoy the smell also. If you don't enjoy the smell, you won't be able to dissect. Okay? So that's how we also did it, and we are still doing it. So it's very important to enjoy what you do. If you see Pablo, he was enjoying the dissection, and it was a pleasure for everybody to watch him dissect. Same thing is in neurosurgery. We enjoy our subject. And if you are not enjoying the subject, then better not to be there. You don't do neurosurgery, and you do not do neuroanatomy. And I like to compliment my anatomy department, who spend a lot of time studying themselves to teach you all. It's not a joke to be a teacher. You have to study, we have to read, and we have to be very perfect while teaching you all, so that we don't teach the wrong things. So I would like to call forward, first, there was a girl who was answering a lot of questions. Can you put your hand up here? Where is she? She's gone? Okay. Because, she knew a lot. So I would like to call Meghna, the students. Who is Meghna? Susan, are you here? Where is Meghna? Come. She's the person who has mobilized all the students, and she has been able to see that all of you all get some important knowledge. Now you'll be able to answer a lot of questions at the exams. You'll still have vivas every 2 weeks, 3 weeks, the first years. I used to dread them. Come, Meghna. Please come over. So give her a big hand. Thank you. Yeah. Thanks a lot. And then first, second, third, I think the third boy or the fourth boy. Prayag, which is the boy? Yeah. Prayag. Come. Please come forward. Don't get affected. See, as this program was going on, I was going behind and watching what you all guys were doing. Sometimes we do it. So please come forward, up. Yeah. So get the bouquet. So this is for you because you slept throughout the program. Huh? Yeah. So it's okay, no problem. Next time, don't do it. Yeah. Okay. It's the guy next to him. He's telling me it's the guy next to him. Please come forward. Don't feel shy. Please come forward. He's telling me there's a misunderstanding. It's the guy next to him. Come. Yeah. Please give it to him. Come here. Please give it to him. So anyway, see, it takes a lot of money to organize these programs. That's what I'm telling you. It's not cheap. See, all this equipment here is very high-end equipment. This costs 4 crores. And if it breaks, this company will lose 4 crores. It takes a lot of mobilization to make these programs a success, okay? Including Professor Pablo, who has spent, a lot of his own money to come here. He has not asked us for anything. He has come on his own. He's booked his ticket, he's booked his hotel room, and he has come here to teach us. So I want students to, you all should value that. You should value. And you should not be sleeping. Okay, fine. If you want to sleep for some time, yes. But be attentive. This happens in class also. But you have missed. Once you sleep means you have missed. Your brain has gone frozen there at minus 18 degrees centigrade. And you have lost. Tomorrow if the anatomy professor asks you the question, you will not be able to answer. And what you will get is a 0. So please don't do that. Don't play with your mobiles when teaching is going on. Senior teachers here, they put their mobiles off. And they were looking at this continuously. So anyway, don't be upset. But this is a learning. It's a part of learning. And I like Dr. Joshi to come here and to give his opinion before we close for lunch.
So very good afternoon to all. It was a wonderful session, seeing the dissection of the fibers of the brain, that is white matter of the brain. I am really very much thankful to Dr. VERNON VELHO, who is all the time very much interested in the academics, in spite of his busy schedule in the operation theatre all the time, and discuss with me regarding that of the CME or anything that you want to keep when we are conducting our workshop. So very much thankful to you this time because all the students, they have enjoyed this. It was a very good academic feast to them. In between, they were there to take the feast of the canteen and they have missed some part of it. So as you have allowed them to go there. But anyhow, the program which was conducted was a very excellent one. Sir, it is not only in the Maharashtra, but outside the Maharashtra also. The anatomists, they have joined and they have gone through this session, and they were very happy to know that such type of sessions are kept by the neurosurgery department with the help of the anatomy department. So once again, I'm thankful to all the senior neurosurgeons who are here constantly. As sir told, they were watching this video. No exhaustion for them, but students were getting little exhausted. As sir has told that when you are seeing this 3D, sometimes your brain is going to get little bit tired. So at that time, you can have a relaxation for 1 or 2 minutes. that's okay. But I'm sure that as sir has told me, even the exams were going on of first MBBS, second MBBS, third. In spite of that, the students, after finishing their examination, instead of going to their home, they have attended this session. So really, I should congratulate them that you have attended, you have taken it very seriously, and by heart, you came here instead of going to their home. So thank you very much. Even thanks to the technical team who has managed this very nicely. The exoscope, as sir has told you, of the 4 crores. So he told me that in the future we are planning to go for this exoscope, which will be really useful not only for their department, for our department. Thank you very much, sir. Thank you.
Well, thank you, Dr. Joshi, and you all can enjoy some lunch there. I don't know whether it's ready. Is it ready? Not yet ready? Okay. After that.